Yeah, Manju ma'am.
Yeah. So, good evening to everyone and welcome to day 2 of the certificate course on complex cesarean section. So, me and Mitra extend our warmest welcome to all of you. And after the resounding success of our day 1, which was attended by more than 1,000 delegates, I think we all are very excited to have you here for the day 2. So I think I will call upon Dr. Sheila to welcome and then move on with the program thereafter. Dr. Sheila?
Yes. Thank you, Dr. Manju. Uh, and once again, I welcome you for second day. And I think we are very happy to have more than 1,000 logins yesterday. And that shows that this is a very important subject for all of us. And once again, I thank all the faculty and everybody for accepting our invitation and being there for this today's program. And without taking much time, I think let us go ahead with this. Thank you, Dr. Manju.
Thank you, Dr. Sheila. So may I now request Dr. Sadhna, who's the Vice Chairperson of ICOG, to say a few words. Dr. Sadhna, over to you.
Thank you, Dr. Manju, and once again, hearty congratulations to whole of ICOG under lead by Dr. Sheila Mane and the supervision by Dr. Pratik and the coordinator, Dr. Mitra Saxena and Dr. Manju Puri, who are already on the go since a long time for this complex cesarean section workshop. I welcome all coordinators. Today's coordinator are Dr. Nivedita Jha and Dr. Ashima Arora. And it is really great to have none other than the guru of guru, Dr. V.P. Pelli, as our esteemed faculty, and beyond all faculties, Dr. Rinku, Dr. Aruna, Dr. Atul Ganatra, Dr. Pradeep Saha, and Parikshit, and Dr. Surekha Taide. Caesarean section is one thing which brings a bouquet and sometimes bricks to obstetrician. And this is the media issue. Everybody wants to know about the rising cesarean section rate. And we are worried about the complexity of cesarean section before table, on the table, and after the table. And this is one of the important concern, placenta accreta spectrum, which is coming in a big way. And I think it is reducing also now as per our observation, and the post-operative complications. So many very good research papers from India says that the complication post-operative, re-laparotomies, the delayed referral, and that is the thing which actually makes that we should take always a cesarean section, a just cesarean section, a well-done cesarean section by a well-defined and the lead with the senior obstetrician and all team with the anesthetist as well as the pediatrician. So we wish everyone a very good, enjoyable learning. The cesarean section has become our bread and butter of our profession, and we should be always ready 24/7 in different settings for doing cesarean section in a best way and very defined way. So warm welcome to everyone, and wish you again a very happy learning. Thank you very much.
Thank you, Dr. Sadhna. May I now call upon Dr. Ashok, who is the chairperson-elect ICOG, to say a few words?
Yeah, thank you, Dr. Manju. Good evening and happy group Purnima to all of you. ICOG has this program over 3 days on debating about and discussing about the importance of cesarean section, which is a bread and butter of all our obstetrician colleagues. So these will review and present to you all the information and updates and what are the tricks to have legal free cesarean section without any complications. So I first of all congratulate Dr. Sheila Mane, chairperson of ICOG, for devising this program, and thanks to our convener Dr. Manju Puri and Dr. Mitra Saxena for organizing such a wonderful program and with lot of attendance, all your efforts. And thanks all the faculty members and all the friends and colleagues who are participating in this program for sparing their valuable time. So without taking much time, I just hand over to Dr. Manju Puri, and best wishes to all of you with the happy learning. Thank you.
Thank you, Dr. Ashok. So I'll begin the day with a little catch up on what we did yesterday. So yesterday was a day which was dedicated to preparedness and anticipation, identification, preparedness, and anticipation. So we started the day with the checklists, and then moved on to what kind of anesthesia, what are the anesthetic considerations as far as complex and high risk cesareans are concerned. Then we moved on to anticipating and preparedness for disimpacting a deeply engaged head. Also about the malpresentations, how should we be prepared as far as malpresentations are concerned. This was followed by a very interesting panel moderated by Dr. Rashmi and Dr. Mumtaz on cot unawares nightwear referrals. So they took up cases wherein seniors are called in the middle of the night for problems. So that is what the panel actually discussed. So it was a very interactive session. Lots of questions were there, which were posted on the chat box, and even the speakers also interacted with the audience. So I'm looking forward to a day 2, which is again, which is an interesting day, where we are going to talk about all what happens in the OT. So day 1 was all the preparedness before the first cut, your readiness, and second is what can happen in the OT. So we'll start the day by none other than guru of all, Dr. Paili, who is going to talk on how to deliver preterm babies on cesarean, which itself is an art. This will be followed by a crosstalk between intraoperative maternal collapse beyond hemorrhage. And so if just the mother collapses, then Dr. Rinku is going to engage and have a crosstalk with Dr. Vivek Saluja, who is an anesthetist. This will be followed by Dr. Aruna Nigam, who's going to help you understand how to make entry into the abdomen in case there are a lot of adhesions. So she will be taking up that. She'll be talking about safe entry into the abdomen because we have so many repeat cesareans now. Session 2 would be a skill enhancing session, which will talk about doing a cesarean section with fibroids, myomectomy to be done, not done, if done, how to be done. Dr. Atul Ganatra is going to talk about it. And then it would be followed by Dr. Pradeep Saha from PGI, who will be talking about how to do a bladder first approach in placenta Accreta syndrome. And we'll end the session like we will do it on all these 3 days with a very interactive panel discussion, which will be moderated by Dr. Parikshit Tank and Dr. Surekha Taide. And that would be tackling on-table complications in complex cesarean sections. So although emergencies have been put as panels so that seniors experienced people can share their experiences and give some good practical tips. So with this, we have a day full of excitement. We have wonderful faculty, very experienced people. And I would now invite our the coordinators. Yeah. So we have 2, again, very young, dynamic coordinators. So we have Dr. Nivedita Jha, who is an additional professor, Department of FOGSI Gynaecology from JIPMER, Pondicherry. A very, very passionate obstetrician. And she was there with us during our workshops on complex cesarean section. I got to meet her and very happy, and I see a very bright future for her. The next we have is Dr. Ashima Arora, another young, dynamic, vibrant, additional professor from the Department of FOGSI Gynaecology. They look very young, but they are very decorated and they're very experienced. And she's from PGI Chandigarh. And again, a very, very bright person and very enthusiastic as far as participation in workshops and academic programs is concerned. So welcome, Dr. Ashima and Dr. Nivedita. I hand over the mic to you. And before that, I would like to remind you that everyone has to again take the post test, right? After the workshop, after the day, we will be putting a test, MCQs, which will be posted at 6:45 p.m. So all of you will have to take and get 50% marks out of it for you to actually get a certificate. So over to you, Dr. Ashima and Dr. Nivedita.
Yeah, thank you, ma'am. Thank you. Both of us are very thankful for trusting us with this role. We are really fortunate to be a part of this feast. No wastage of time. Welcome, everyone. You all are our seniors. So happy Guru Purnima. I'll introduce directly the chairpersons for the first session, Dr. Amita. So many awards to her credit. She is working as consultant OBG at Allahabad, has been honorary secretary of the Menopause Society, the vice president of the society, has been awarded the Vidya Bhasin Award and the Kamla Acharya Award, and has special interest in high-risk pregnancy. Welcome, Dr. Amita. Then we have Dr. Chandrakant Sankalecha. Sir is working as consultant gynecology at Sankalecha Hospital, Nasik for more than 35 years. Has a huge experience of serving probably all the societies in his region, and has special interest in high-risk obstetrics. Welcome, sir.
Hello. Hi.
And thank you, sir, for joining us. And Dr. Nupur. Dr. Nupur she's a professor in Kishanganj MGM Medical College, Bihar, with an experience of more than 25 years of UG and PG teaching. Thank you, ma'am, for joining us. I would request Dr. Amita to please introduce, though Dr. Paili needs no introduction, just a formality to introduce our first speaker for today.
Thank you, Dr. Ashima. A very good evening to everyone. Thank you, Team ICOG, Sheila ma'am, Pratik sir, Sadhna ma'am, Ashok sir, Manju ma'am, Mitra ma'am, for giving me this opportunity to chair this prestigious session of Dr. V.P. Pelli sir. Regarding topic and our esteemed speaker, we are increasingly delivering these delicate babies because of rising IVF conceptions, and it poses a unique challenge. And today, to deal with this topic, we have none other than the Gurus, Dr. V.P. Pele, MD, FRCOG, is National President, Society of Vaginal Surgeons of India, past President, Kerala Obstetrics and Gynaecology. There is previous state coordinator of confidential review of maternal deaths in Kerala, consultant, Rajagiri Hospital, Alvae, Ernakulam district, Kerala, and his special interest is high-risk pregnancy, pelvic floor surgeries, and urogynecology. Sir, the stage is yours. Please enlighten us about this delivery in the extremely preterm babies. Please, delicate.
Thank you very much. Can I share the screen first, please? Thank you very much, Dr. Sheila and Ashok, Preeti, Parishit, Mitra, Manjula. I don't want to repeat all the names. Thank you very much for this opportunity. And I have been asked to talk.
We can't see your screen. We are seeing the browser window. You have to share the PowerPoint.
Can you see now?
Yes, sir. We can see, sir. Please, if you could put it in the slide. Yes, sir.
Thank you.
Perfect.
I have been asked to talk about complex caesarean sections or the delivery of the extremely preterm babies. Delicate deliveries they are, no doubt about it. And very pertinent topic, as was mentioned in the initial phase, because of the type of obstetrics we are dealing with changing, the need for delivering extremely preterm babies also will be on the increase, no doubt about it. So very pertinent topic. I would like to then bring out a few points and then show you some of the videos. That's the plan. Very often it will be associated with IUGR. So all the complexities of dealing with an IUGR baby comes in. And the other problem is there may be a non-formed lower segment. In other words, a very thick lower segment. You have to think of delivering a baby through a lower segment, which is very thick, and it has its own problems. So these are the few things to keep in mind. I think many of these patients, especially if they are extreme preterm, and as was mentioned earlier, preterm, IUGR, or IVF babies and all that, very likely that they may be on some antiplatelet agents. So check in the history. Check if there is an IUGR associated with it. Management has to be varied according to that. And the presentation, very likely that there will be abnormal presentation when it's an extreme preterm baby, because as we know, At about 28 weeks, about 25% of the babies may be breech and relatively larger head compared to the body. So these are a few practical points we have to keep in mind. We have to decide on the type of incision on the abdomen, on the uterus, and whether any instrument is needed to deliver. Check whether the placenta is under the incision. These are all the practical points to keep in mind. And the general point to keep in mind is a preterm baby needs very gentle maneuvering. You cannot just pull out like that. The bone will be fracturing in no time. So we have to keep that in mind. And the other point, which is sometimes taken as something not to be done by in many teaching centers, is the use of under pressure. We can pull a baby out, but whenever we are pulling a baby, whether it's a breech first or a head first, there's a chance of extension. And when the head is extended, more problems come in. So I would suggest, along with controlled delivery with traction, there should be under pressure utilized in delivery, whether it's a breech or a head. And then if there's a placenta under the incision, which again is likely to happen in many of these, don't cut through the placenta. I'm not talking about, even if it is not Accreta, don't cut through the placenta. I will show you with videos how to tackle that. And to help the baby out, we cannot think about ventouse. We cannot put our hand through a very thin, a very thick, narrow lower segment where the incision that you make, even if it is say 8 centimeters, when the liquor goes out, it may come down to 5 centimeters. If you put your hand there to guide the baby's head, that will take away a lot of space. So you should have forceps for delivering these babies. And it's a preterm, extreme preterm, less than a kilo, we should have special forceps. So that is why we have developed these forceps, which in this magnification, it may look like a normal one, but this is our regular forceps. See the difference. So we have a mini forceps developed, which can be used to deliver a baby, which is smaller than a kilo. Before planned delivery, discuss with the parents about the plan of resuscitation. This I am saying because you may take out a baby alive at say 600 grams, and what will happen to it in the next 5, 6, or 8 weeks is important, the cost involvement. So we have to talk to the relatives, parents, as well as the neonatologist should be involved in the counseling. Gentle handling, which I already mentioned to you, and do an ultrasound before you take her for cesarean so that you will know exactly which way the baby is lying. You cannot go around palpating. Here will be a situation where it's a small uterus, very often less liquor, and you cannot go and do a lot of maneuvers. So do a scan prior to taking her for cesarean section. Now, as I mentioned, if she is on antiplatelet agents or like aspirin, a vertical abdominal incision. Keep that in mind, because if you put a transverse incision, the chance of bleeding when you separate the recti is more, and behind the rectus sheath, rectus abdominis, there can be hematoma formation also. Now, incision of the uterus. If it is a narrow uterus, thick lower segment, and putting a transverse incision as usual in the lower segment may not be always advisable. If she is in labor, maybe it is a thin, but if it is elective, better to put a vertical incision starting in the lower part of the abdominal incision, extending to the lower segment. That will give you the option to extend the incision. Whereas if you put a transverse incision and it's thick lower segment, and then if you want to extend it, the hockey stick, inverted T, all these things come in. So better to put a vertical even in the lower segment. The placenta is under, as I mentioned earlier, don't cut through it, separate it, go to the level of the membranes and deliver it. With Accreta, of course, don't disturb it and put the incision away from the placenta. Under pressure, I already mentioned to you. For delivery of the head, use the mini forceps, which I told you, this one, we'll show you with videos. Do not use the ventouse. And then, if the patient has not had steroids, see if there is appropriate to give it, whether it is time for it to act. And similarly, for neuroprotection, consider magnesium sulfate. If there is cervical insufficiency, and that's the reason for you to deliver, think about appropriate advice for future pregnancies. Let us see this pregnancy, placenta previa, engorged vessels in the lower segment, and forceps for head, what we are doing here. you can see the engorged vessels. You go to a side and there you can see some of these vessels. You can even underpin some of them before you make an incision. If you just boldly make an incision into such dilated vessels, in no time she can lose a lot of blood. And remind you, here there's a baby which is having very little blood. This blood loss is mother's, of course, but you are likely to take longer time. So this is one thing which I would suggest. Tie above and below the proposed level of incision and then only incise the uterus. And when your uterus incision is put, again, remember here, you should not cut through and through the myometrium until you have reached the membrane and rupture it, because you can injure the baby when you do that. So make the incision. So you can see that it is a thick lower segment. And there, make the incision bigger, and you see the placenta there. Move the placenta to a side, go to the level of the membranes, rupture it, and there feel where the occiput of the baby is. Take the forceps in your hand. Even though it's a mini forceps, it has got a little pelvic curve. Keep that pelvic curve towards the occiput of the baby. And then lock the forceps and try to pull the baby out with the occiput leading, because if you don't take this care, you can have either damage the baby or extension of the incision. And you can see that after delivering the baby, we are going to tackle the placenta after that. So apply the forceps, biparietal application, and complete the delivery. That is what I would suggest. Again, another one with the use of the forceps, what we can do in this case, again, lower segment. Even in preterm babies, there will be a lower segment. You can see the peritoneal cover. For that, you make the incision. Don't try to reach the membrane and try to get the membrane bulge out. It may not always happen. You can extend it either with scissors. If you are using, make sure the scissor blades hugs the uterine wall. Palpate the baby which way that is lying. And then take the assembled forceps, the occiput, there is a little pelvic curve here. Keep that towards the occiput of the baby. And having applied it, pull it so that the occiput leads when it comes out. And this is how we deliver these preterm babies. If it is a placenta underneath, as you can see here, again a vessel over there, transversely. The membrane is bulging. You can see the placenta by the side. In this case also. Rupture the membrane and feel the baby. Go with the forceps, because if you have your hand and do the usual levering out of the head, that can take away a lot of space. The liquor is clear here, and you can deliver the baby like that. So I think again, you can see how small baby it is. These babies do not tolerate our rough handling. That is the one thing that you have to keep in mind. So this is the suggestion I have. If it's a preterm baby, you should have a plan in your mind, instrument to assist the delivery. And if you are interested, there's a masterclass training that the Thrissur Society does. Anybody interested can take a snapshot of it. If you can call them at these numbers, there is a training program where we give a 2 days intensive training, only about 8 to 10 people per batch. And with mannequins and models, we give them training. And there is, of course, another training program for vaginal surgery. Thank you very much for the opportunity to share with you some of the thoughts we have regarding the delivery of the extreme preterm baby. Thank you, chairpersons. And of course, Prateek, thank you very much for the opportunity.
Thank you, sir. It was an excellent deliberation. Sir, what is your opinion about end-call deliveries? I've read some in extremely preterm. Some people use delivering these babies in call.
The advantage of in call, that is with the membrane intact. That's what you mean, isn't it?
Yes, yes.
The advantage there is probably different ones. One is of course, you get the baby less likely to get traumatized by our handling because there is a protection of the membrane maintained. If you can maintain it like that, there's nothing wrong with it. Only thing is, when you're trying to deliver with the membrane intact, there is a likelihood that the placenta also is likely to get separated prematurely. And once you have got that, the time becomes critical. Otherwise, I don't know whether it is that much important. In practice, we don't try to do it, but sometimes it may inadvertently happen. That's all. I don't think about deliberately trying for it.
Thank you so much, sir. It was wonderful talk. You have explained all the things very well. The gentle handling, the use of modified forceps, and the videos were wonderful. Thank you so much, sir. Thank you, sir.
Ashma, you can
Thank
take
you.
some questions
Yes,
we have done.
Yeah. Yes.
Can we take?
Yes.
Yes.
Okay, ma'am.
One thing, sir, it is always a pleasure to listen to you. One thing I will just share that we are today, nowadays, aspirin is so rampant. But in our experience, we do the transverse incision, very careful about catching leader and looking for the rectus leader, any inferior epigastric artery. And the transverse incision, actually, because vertical, when it goes a little bit higher, it is not in our control. But the transverse incision is quite in our control. So just say your comment that you always prefer vertical or in certain situations.
Sadhana, you're talking about lower segment incision or abdominal incision?
Both. Sir. Vertical in the anteplated. Yes, both.
Abdominal incision, we are very particular that we put a vertical only because once you stretch even the recti to get the space there, the inferior epigastric with the veins surrounding the arteriole is likely to form, not immediately bleed then, but likely to bleed later. And so vertical incision, the main problem is cosmetic. We can put the vertical in the midline, and here most of the time, because the umbilicus also has shifted up, there will be no space in the lower part to keep the incision infraumbilical. Second thing is, what about the way we close it? We can do subcuticular closing for the vertical incision also, so the scar doesn't become like the typical centipede scar. So we feel that it is better to have a vertical incision on the abdomen. If you have to do an incision on the abdomen in somebody who has a coagulation problem, DIC, or has been on heparin or on aspirin like that. That is our thought. Of course, we will try to counter the effect of the aspirin and all that by putting in fresh platelets and all that, but that may take time. It may not always work. So abdominal incision, we feel that vertical incision helps, but it's not a must. You may sometimes put a lower segment incision, lower abdominal incision transversely. You can end up with the chance of more bleeding and more hematoma formation. But the lower segment is more important. The lower segment, when you look at it after opening the abdomen and feel that it is very narrow lower segment, and if you do for your conventional method of separating the utrovesical fold of peritoneum and go incision at that level, the width that you get will be only about 4 to 5 centimeters. And the moment you have incised and the liquor escapes, these 5 centimeters become 3 to 4 centimeters. And through that, even to take a baby, it will be a traumatic delivery. Even these mini forceps which we have developed, even this one may be traumatic to the baby if there is not enough space in the lower segment. A thick lower segment is traumatic, as traumatic as when it comes through a vagina also. So in that case, it's better to have a vertical incision. And at least in our stage, the good thing is people usually don't go for 10, 12 babies now, maybe 1 or 2. So even if you put a vertical incision, another cesarean is okay. If you put a transverse, again a repeat cesarean is the norm almost always. Even without cesarean, people are going for primary cesarean 90%. So that way, we feel a vertical incision will help us to deliver with less trauma. That is the point I am trying to make.
Thank you, sir. Thank you.
Sir, I'll take some questions from the chat box, though.
Please do.
Like somebody has asked, is it must to use these forceps? So obviously, what we mean to say is it is not must, but they're
so what I meant was, see, in case you have to help out. Suppose you have a patient in labor, a preterm patient in labor, thinned out lower segment, make an incision, the baby jumps out, no reason for that. If you have to help out, the usual concept that we have is put your hand, half hand in and push from above, have a levering out. That may not happen here because that little space already available at the incision will be partially taken by our own fingers and the baby will have little space to come out. If you have to deliver, you use something to pull. You cannot apply the ventouse in any baby below, say, 34 weeks. So the only option is the forceps. And the other advantage of the forceps is, see, when you are applying the forceps and you can make the occiput lead. If you just push from above, you have no control which way the head is coming. Whereas if you have a forceps blade applied, you can make the occiput lead. And the importance of the occiput leading and a deflexed head, only when you experience, you will understand. Because when the occiput is leading, certainly it leads to less trauma for the baby, less likelihood of extension. So this is the other reason. But it's a thin lower segment, maybe you can escape without it.
Yes, sir. And so somebody has asked, can we convert to breech and deliver?
I actually have delivery of the breech here, but because of the time I didn't show it. But yes, you can, but that is not advisable here in an extreme, unless it's a transversely lying baby. The reason being, more trauma is likely to occur by going around turning a baby. The one thing that surprises many of us, those who have experienced will, is how easy it is to break the baby's bones. When you want to break a clavicle for a shoulder dystocia, it won't break. But the moment you hook out a humerus or a femur, you hear that sound. It breaks. So the good thing is, of course, it will heal very well. So I would not recommend deliberate manipulation of the baby to convert it to from a buttress to a breech and all that. But if it's even if it is a breech baby that you deliver, preterm baby, according to me, you need forceps. Because otherwise, when you pull, the head gets deflexed and you present bigger diameters and you have a problem. So deliberately changing to breech, I don't think is a good strategy. You may have to if it's a transversely lying baby, but otherwise I wouldn't. And maneuvers like Patwardhan, I think in these cases, you try to avoid them.
Yes, sir. So for these delicate babies, we would not be advising something like Patwardhan. So the last question we'll take up, somebody has written, is vertical incision on uterus, will it be a contraindication for a trial of labor the next time?
Yes.
So as you said,
you
already said that we are hardly having 1 or 2 cesareans per mother these days. So if that is the preciousness of the pregnancy,
I would not recommend a trial next
trial.
Sir.
Yes, sir. Yes. Thank you, sir. Thank you so much.
Thank you.
Thank you, sir. There are endless questions to you, and the screenshot that you have shared, sir, please put it on the group also, because some people want it again. So we'll circulate that masterclass.
It is there. Do you want me to put it now?
Sir, no, sir, we'll put it in the...
Sir, I put your email ID, so whoever wants to, they will mail you. I've given your email.
The numbers are in that slides which I showed you, so they can directly contact actually.
Right.
If you give permission, I will write your number also then.
All right. Okay.
I'll do that.
Thank you. Thank you,
Thank you, sir.
Thank you very much.
Sir.
Thank you, sir. Thank you, Amita ma'am. I'll invite Dr. Chandrakant now to invite our team of the OBG and the anesthesia consultants for a crosstalk.
Yeah. So good evening, everyone, and greetings from Nasik. The next talk is on the collapse of a woman on the table at the time of Caesarean section. The speaker is Rinku Sengupta, who is the senior consultant at Holy Family Hospital, Delhi, and her area of interest is quite interesting. Actually, it is reducing intervention in obstetrics. I think going back to the natural ways, and she has been finalist for reducing Caesarean section in private setting in Delhi in 2014, which is again interesting. She has been executive member of Safe Motherhood Committee of AOGD. So I welcome her. Along with her is Dr. Saluja, Dr. Vivek Saluja, who is consultant anesthetist and works in many Cloud9 hospital at Gurugram. So it's an interesting debate because these are the obstetrician and anesthetist. These two people are there in front of whom such catastrophe occurs, and they have to be very alert and they have to be on their toes and do many things at one time, like simultaneously, to diagnose and revive the patient. So over to you, Dr. Vivek and Dr. Rinku.
So a very good afternoon to all my respected seniors and junior colleagues. Thank you so much for this opportunity. I'll start sharing my slide on behalf of Dr. Saluja and myself. Can you see our slides?
Yes, ma'am. We can see them. Please put them in the... yes, perfect.
Is Dr. Saluja here? Dr. Saluja?
He had joined, ma'am. You can, ma'am, do you want to start at the same time? If you want to start, otherwise I will check. If he's
I'm here, don't worry.
Okay.
Good evening.
Okay,
Good
sorry.
evening, sir.
So I think there are very few clinical situations which call for our best medical and surgical skills and our physical and mental endurance as intraoperative maternal collapse. Now we will, of course, focus only on the cases which are not hemorrhage, because we have a lot of sessions on hemorrhage. And without wasting much time, we'll dive into the cases straight away, and Dr. Saluja will take us through. Please, Dr.
So a very
Saluja.
good evening. Yeah, a very good evening to everybody. Many thanks for inviting me. So we'll not waste much time. Our plan is we'll introduce 4 cases first, and then we'll go on to maternal collapse in the OT. So the first case is a 32-year-old term primary gravida with no comorbidity. We gave her a labor epidural through the combined spinal epidural technique when she was 3 centimeters dilated, about 40% effaced. She had good pain relief. In fact, she only needed 1 top-up dose during the entire time to her full dilatation, which occurred after about 6 hours. However, due to failure of descent and fetal bradycardia, it was decided to do a Caesarean section. We shifted the mother to the operation theater, attached the monitors, and then over there we gave an epidural top-up consisting of 15 ml of 2% xylocaine with adrenaline. However, within about 2 minutes, the patient had acute breathlessness. She suddenly stopped talking, began whispering, and was unable to talk. Her pulse dropped immediately to around 48 per minute, and her blood pressure was recorded as 80/50. Can I have the next slide, please? Yeah. So this is a diagram over here which shows us a bit about the area where we give the centenary axis block. As you can see, the epidural is just one space outside the spinal space. And it is a very thin membrane, the dura mater, that actually separates the 2 spaces. Okay, so going back to our next slide. Next slide, please. Okay, so immediately as she was unable to talk and her blood pressure and heart rate was going down, we started oxygenating her with the bag and mask. We made an immediate provisional diagnosis that something had gone wrong. Most probably it would have been a high spinal. So as she became unconscious, as she stopped talking and we knew that she was awake, we induced anesthesia with injection propofol and then intubated her trachea with a cuffed endotracheal tube. There was no need to give a muscle relaxant as everything was relaxed. Immediately, the Caesarean section was started. Side by side, because her blood pressure had gone down, we started an infusion of noradrenaline to maintain her blood pressure and mean arterial pressure of more than 65. And thankfully, we were able to deliver a baby within about 2 minutes with APGAR scores of 7 and 9. We ventilated the patient post-operatively, and fortunately, she had a full recovery within 4.5 hours. We were able to extubate her trachea uneventfully, and she was discharged after 3 days without any long-term neurological problems, without any post-spinal headache also. So next slide.
So I just wanted to ask you, Dr. Saluja, because we are using epidural analgesia so commonly these days, how often do you find epidural catheter migrating into the subarachnoid space? Is it common?
It is not very common. In fact, this is only the second case that I've seen in the past 20 years that I have been giving epidurals to mothers, and but it is a catastrophic thing that happens if you don't recognize it at once.
Yeah.
So what it means is that
yeah.
right. So what it means is that all mothers with epidural analgesia have to be monitored carefully. There should always be an anesthetist within the hospital, preferably on the same floor. And if the patient has gone into the theater for a cesarean section, the anesthetist has to be present round the clock. I mean, as long as the patient is inside. So always be aware of epidural catheter tip migration.
So before you give the dose, like how do we be sure that it is not, we have to give a small dose first? Yeah.
Yep, we actually give aliquots of doses. You should aspirate with a 2 or 5 ml syringe and see that there is no CSF that is coming out or any fluid coming out from the epidural catheter, and then you give the drug. So in this patient, we did do it in such a manner, but we waited for about a minute between giving 2 aliquots of 7 ml each. But when there was a cumulative effect, that is when suddenly the spinal rose and it became a total spinal.
Right. And you don't think it is more common with CSE, no? Like nowadays we are giving CSE more commonly, no, than epidural.
No, it's not actually more common with CSE. It can have the epidural tip can migrate even if a CSE is not used. Even in a plain epidural, the tip can migrate.
Right, right. So can we go on to the second case? Yeah.
Yes, please. So the second case was a 32-year-old lady who, with a previous CS planned for an elective cesarean section. We gave her a prophylactic antibiotic, ceftriaxone 1 gram. IV infusion was started 15 minutes before the surgery after the test dose was negative. 10 minutes after the infusion started, she complained of acute breathlessness, chest tightness, and itching all over the body. There was a slight rash that was present on the chest and arms. Her heart rate had shot up to about 120 per minute. BP had dropped. There was wheezing present, and her saturation had gone down. The patient became drowsy, and her heart rate then suddenly went down, and her peripheral pulses were not palpable. Immediately, we suspected that there was anaphylaxis. Now, the thing that is important is that whenever you have anaphylaxis, there is only one medicine that works. Please forget Efcorlin, please forget Lasix, or please forget Avil. Give adrenaline only. So what we did was we stopped the antibiotic infusion at once, gave her oxygen by face mask at about 15 liters per minute. Injection adrenaline 500 microgram IV push was given. We had to repeat it again after 2 minutes. The left uterine tilt maneuver was done so that we prevent aortocaval compression, and we nebulized Volin, 2 respules, one after the other with oxygen. Because there's going to be extreme vasodilation, you rush about 1500 ml of ringer lactate. And now comes the time when you give antihistaminics, both H1 and H2, and give hydrocortisone 200 milligrams. So thankfully, she responded to emergent treatment. We kept her in the preoperative till full recovery and did the cesarean section once she was stable after 2 hours. Now, it is important to know that anaphylaxis can happen to antibiotics, and it can also happen with syntocinon. I have seen it happening with oxytocin in one patient also. So the thing to note is that it is rare, but it can mimic spinal hypertension. Whenever there is a bronchospasm with rash and a collapse after drug administration, always suspect anaphylaxis. Adrenaline IV or IM is the first line of treatment, and it is the delay in adrenaline administration that leads to mortality. If there is no response to adrenaline, then plan for a perimortem cesarean section within 4 minutes of the patient having collapsed. And always remember, a negative skin sensitivity does not rule out anaphylaxis.
So I just wanted to ask you, Dr. Saluja, supposing we had this anaphylaxis on table, would we have advised simultaneous baby delivery?
If the spinal had already been given, right, and suppose you had already made the first skin incision whilst we were giving the medicine, then you would have probably continued for the cesarean section at once.
Simultaneously.
Simultaneously.
Yeah.
And remember that adrenaline would have to be given. It's absolutely safe because even the baby would be at distress, and that would help. The adrenaline would help the baby also.
Right. So moving on to the third case.
Okay, so over here we have a 35-year-old primey with twins planned via IVF, planned for cesarean section. She had preeclampsia, not very severe. She was on labetalol 200 milligrams twice daily. No history of gestational diabetes or any thyroid disorder, no drug allergy. Her heart rate was about 110 per minute. Blood pressure was 150 upon the higher 90s. Pedal edema was present. And she was slightly tachypnic with an SpO2 of 96% on air. And she said that this had been going on for the past week. On auscultation, there was decreased air entry at the bases. Next slide, please. Right. Okay, so she was planned for a cesarean section under regional anesthesia, spinal anesthetic. So after delivering the baby, there was active management of the third stage done, and we gave her carbetocin, 100 milligrams IV, and because there was mild PPH, we gave her carboprost, 250 micrograms intramuscularly. After about 10 minutes, the patient complained of breathlessness. Her heart rate was around 110 per minute. Saturation had gone down to around 88%. The air entry had further decreased bilaterally, and there were occasionally a few crackles or fine creps, which was progressively worsening with increasing dyspnea. Next slide, please. Now, because there was PIH, we had a suspicion that she may have progressed to peripartum cardiomyopathy of pregnancy. There was also this chance that maybe this was due to a bronchospasm due to the carboprost that was given. The carboprost that was given. However, we decided to do an echocardiography on table itself because we have a ultrasound machine over there in the theater. Now, the limited view that we had showed that there was global left ventricular hypokinesia. And we made a provisional diagnosis of peripartum cardiomyopathy of pregnancy. We started Lasix 40 milligrams IV at once and started her on BiPAP support. They gave her a slight 15-degree head-up tilt, as much as was possible. The surgery was completed at once, rather rapidly, thanks to our obstetric colleagues, and we then shifted her to the ICU, where she was formally evaluated by the cardiologist after some time. Now, after Lasix and giving her BiPAP support, her urine output increased after about half an hour, and then she didn't begin to stabilize. And we then gave her further Lasix once we knew that she was improving. We have one big advantage over here, that the treatment of left ventricular failure is the same, whether it is due to cardiomyopathy, whether it is due to valvular heart disease or anything. So that way the gods have been slightly kind. Next, please.
So I just wanted to know, how do you differentiate between something like amniotic fluid embolism? Because in this, of course, it is very rare. We understand that. But like soon after delivery, the mother collapsed in this case, although it was not very sudden. So clinically, yeah.
So see, if it had been amniotic fluid embolism, we would have expected a lot more respiratory distress. Her saturations that have actually gone down, she would have become hypotensive. And the mother herself would not really have, she would have also become slightly unconscious.
Yeah.
And it would have been a more drastic
sudden
presentation. It would, rather than this.
More dramatic, yeah.
Oh, yes.
Please.
So now we should realize is that peripartum cardiomyopathy is becoming more and more common. What we saw once a year, we are now seeing about twice a month. And the early signs of dyspnea, orthopnea, edema should not be dismissed as physiological without further investigation. And echocardiography in elderly patients should now become part of our standard of care rather than when we think it is emergently required. And it also means that with all anesthesiologists should attain basic echo skills now. The time has come.
Do you also recommend antenatal echo in some of these mothers, the IVF elderly ones?
So, yes, the elderly parturients, especially with the artificial assisted reproductive technology or IVF, hypertensive disorders, we should get an echo done in all of these patients. Any patient who complains of breathlessness, especially in the last 4-5 days, we should get it done.
Right. Yeah, moving on to the last case.
I'm sorry to interrupt, though it's going perfect. There's a little crunch of time. Sir, we'll take up this case, but a little quicker. Sure.
A bit fast.
Thank you.
Right. So,
yes, sir.
So
and sir, your hand is obstructing
we will give
your
5
view.
minutes. 5
yes,
minutes.
Ma'am,
5 minutes. Extend it.
So we can't see you clear. Yeah. Thank you, sir.
Right. No, it's okay. All right. So we had this patient who came for a term pregnancy with previous LSCS. She was admitted for an elective cesarean. She gave us a history of a mild headache for the past 5 days. However, there was no history of breathlessness. And a cesarean was planned after spinal anesthesia. So the patient delivered the baby uneventfully. However, after about 15 minutes, she had a generalized tonic-clonic seizure and became unconscious during the uterine closure. Next. So we gave her 2 milligrams midazolam intravenously to control her seizure and started levetiracetam 1 gram intravenously. Also, magnesium sulfate 4 grams IV over 20 minutes was given and a 1 gram per hour IV infusion started. She regained consciousness in about 15 minutes. There was mild postictal confusion, but she was responding. We shifted her to the ICU. Unfortunately, she had mild loss of vision and after about an hour had another generalized tonic-clonic seizure. Her blood pressure at that time was about 160 by 104. Again, midazolam was given. Now, since we had to send her for an MRI and we decided that if she has a further seizure, it's better to maintain her airway. So we electively ventilated her until we could make a diagnosis. To control her blood pressure, levetolol infusion was started and magnesium was also continued. The MRI revealed that she had what we call depressed syndrome, posterior reversible encephalopathy syndrome, seen often with patients who have PIH or those who complain of headache. Now you must, if PRESS is there, you have to look out for pulmonary edema and renal dysfunction also. So never ignore a headache in a parturient. Seizures in pregnancy do not mean eclampsia all the time. Please rule out cerebral venous sinus thrombosis, intracranial hemorrhage, ischemic strokes, and brain tumors. And remember, magnesium sulfate is the anticonvulsant of choice in pregnancy, both in PIH as well as in PRESS and other conditions.
I think Dr. Saluja, you carry on quickly because time is less. I mean,
so I think what we'll do is we'll go on to the last 3 slides, right?
Yeah.
This is right. So all that we would like to say is that please go on one. So the management of let's go to the medical legal part. And
okay.
Right. So what you have to see whenever you have a cardiac arrest in pregnancy, these are the things that you have to note. Note the time of arrest, the time of anesthesia, and time of delivery. The diagnosis with period of gestation must be given. Strictly note the time of initiating ACLS or CPBR, the time of definite airway management. Make sure that you mention that you gave a left uterine tilt. Time of administration of drugs and defibrillation, volume of blood or balanced salt solutions, that means renal lactate infused, what EtCO2 levels you attain during resuscitation, because they do talk about your level of resuscitation, the adequacy, whether an echocardiography was done, and the time of initiating perimortem Caesarean section with respect to the arrest time. Next, please. Okay, so preoperatively, always document when you complete your file. If you have had an adverse event, make sure that you have a documented pre-anesthetic checkup, documentation of all known risk factors, and you should also show that there was preoperative optimization as per all known risk factors. And make sure that all cross consultations that are done are mentioned and are available in the file. Intraoperatively, please document the type of intraoperative monitoring used. Make sure that you document large bore IV cannula in case there was anticipated hemorrhage. Monitor blood loss on a regular and continuing basis, and there should be very clear documentation of resuscitation. Next slide, please. Okay, post-resuscitation, the anesthesiologist and obstetrician must document all incidences in concordance. The file has to be in sync and filled together. The CMO of civil surgeon of the area has to be informed by the hospital administration on the same day as it is a reportable incident, and therefore it is safe to do it yourself. And the patient's attendants have to be sympathetically informed about the incident. It always helps if the baby could be saved. That is why a perimortem Caesarean section should be practiced and trial runs should be done. Next slide, please. So thank you for your patience. I'm sorry we shot up over time, and may you never have an on-table maternal collapse.
Yeah, thank you.
Thank you.
Thank you, sir. Ma'am, do we have time for 1 or 2 questions?
I just have one comment to tell Dr. Vivek. That a lot of people want your presentation because we've not been able to read everything. And every single line of your presentation is for us. So please be kind on behalf of my whole audience. I request you,
Sure.
Rinku. Thank you.
Dr. Rinku will do it. She has the presentation and it's
Rinku, that was
distribute.
excellent. Rinku, that was excellent.
And ma'am, these were real cases. I think Dr. Saluja. Yeah.
These are all real cases. I mean, these are things that have happened.
Yeah.
Sir, just one line more about adrenaline. Everybody in the chat box wants to ask. They have asked about dose, dilution, mode. So if in one line you could summarize that.
Okay, so the ampule that you get is 1:1000. You have to give half ml of that, IM or IV.
For anaphylaxis.
Half ml, give it IM for anaphylaxis. Okay, that is the safest.
And so one more question that has come up for the seizure, seizure case. Why was Levipil given? Because as a routine for the seizure, first thing Maxel would be given. So do you practice giving anti-epileptics routinely?
Now we weren't sure why she had that. Her blood pressure was relatively normal. If there was any other reason, suppose she had cerebral venous sinus thrombosis or she had anything that any other pathologic cause of a seizure, levetiracetam would have helped. So one single dose was all right, and it is the safest anticonvulsant that you can use in pregnancy.
Yeah. A comment from Dr. Manju. Dr. Manju.
So excellent panel, Dr. Vivek and Dr. Rinku, and I'm glad that you are focused on adrenaline because a lot of our patients even get IV, FCM, and iron sucrose. So they all need to understand that adrenaline is a drug of choice. And the second important thing which you have said is that one has to understand what is going on. And in case the patient is under anesthesia, you should deliver the baby immediately. But if the patient is not under anesthesia, then we can, be ready with the Caesarean section anytime. But at the same time, the patient can be stabilized and, depending on whatever is the cause. Say in anaphylaxis, you wait it.
Yes.
Right. So that understanding also has to be there. Yeah. So I think they were very interesting. Yeah, stabilize the patient. It is not that in panic every time, try to move the baby. So if we can understand the cause, then we can understand it better, right?
Yes.
Thank you so much. Great.
Thank you. Thank you. Our pleasure.
Okay. Thank you, ma'am.
I would request the chairperson to please wind up this talk so that we proceed. Thank you, Vivek.
Yeah. Thank you, Dr. Rinku and Dr. Vivek, sir. It was a very nice and very relevant presentation because that is a dreaded thing to have, and you gave us clear insights into basically diagnosing fast what it is and then the basic steps of resuscitation and management. Thank you so much.
Okay, thank you.
Thank you, sir.
Thank you so
I would request Dr. Nupur to please invite the third speaker.
Yes, thank you. So after a mesmerizing presentation by BP Poily sir and the last session, the crosstalk was so interesting, conducted by Dr. Rinku and Dr. Vivek. Now I am going to introduce Professor Dr. Aruna Nigam ma'am. She was former HOD, Hamdard Institute of Medical Science and Research, Delhi. And now she is the president of Indian Society of Colposcopy and Cervical Pathology. She is the president of Narchi Delhi group. And definitely she is an ICOG member. She has publications of more than 250 in her bag, and she was awarded top 5% scientist all over the world by SciRank Global Registry, and so many citations of her publications. She will be talking, I'm not going to detail, but she will be talking into the very important topic of today's, because of increased Caesarean section and patients' late age pregnancies, they might have prior operations. So the topic for her is abdominal adhesions, safe entry, and bladder dissection. Over to you, ma'am. Please continue.
Thank you, Dr. Nupur, for nice introduction. And first of all, I would like to say Happy Guru Purnima to all. And I got a chance to speak today on the occasion of Guru Purnima. And moreover, in the session where Dr. Paili has talked. So I am fortunate enough today. So all blessings have come to me. So I'm now going to do some justification, trying to do some justification with the talk, so that maximum things I can impart whatever I have learned in last 25 years. So let's talk on abdominal adhesions, safe entry, and the bladder dissection. So what I'm going to take on in this lecture, what are the sites of adhesions, anatomical relationship of those adhesions, why to separate bladder, how to deal with the adhesions, and at the end, we are going to show you the policy maneuver. And I will request all of you to go through this FIGO article on complex Caesarean section, a very informative article. So whenever you are doing a previous Caesarean section, always think of that you have to anticipate for any surgery. You need to anticipate the complications, and you need to plan how you are going to manage those complications. So let me ask you one thing. You can see two pictures here in this, right? Do you think there is any association between the type of scar and the intra-abdominal adhesions? Yes. So we always think that the bad is the lower one is going to have a lot of intra-abdominal adhesions, but this is not the case. If you see, we all know that midline scar are 67% more associated with the intra-abdominal adhesions as compared to phalansteal scar. But there is no clear-cut association between the character of the scar and the adhesion. So this case might not have any intra-abdominal adhesion, but always anticipate and plan. What are the various sites of the abdominal adhesions? Very important to understand. So we can have adhesions between the rectus and the uterus, rectus and the bladder, uterus and the bladder, and bowel and the uterus. And I'm going to take on the first three. And what are the major complications which we anticipate? Injury to bladder, bowel, and uterine serosa. Why I'm saying uterine serosa? Because the rectus is totally adherent to your uterine wall, and once you are separating the this rectus muscle from the uterine serosa, inadvertently you are going to cut over the serosa, which is going to bleed. Difficult entry and increased incision delivery interval. A word about why we need to separate the bladder adequately. Suppose you have entered in the abdomen. You are seeing there is an upper segment junction of the upper and lower segment. Why to go down? Let's leave the bladder. No, you should not think like that. You should be separating the bladder adequately, because you can have a bleeding during your procedure, or you might have to take a Belen suture. Whenever we are taking a Belen suture, a good amount of lower uterine segment should come so as to have a good compressive effect. Or you might have to take a uterine artery ligation. Again, the bladder should then be nicely separated. So you always have to anticipate and do the things beforehand so that the future is better, right? You might encounter unnecessarily the lower segment bleeding, and then you have to tie a tourniquet and tying up a tourniquet too high, not covering the lower part of the lower uterine segment, you are going to leave the sector 2 bleeding, which is because of the colpouterine arteries, and your uterine artery ligation is not going to have any effect on that. So for that purpose, you need to have a sufficiently bladder down, or you are dealing with the placenta accreta, percreta, and you need to proceed with the hysterectomy. So bladder should be nicely down, adequately down, so far as possible, to have your comfortable surgery. And I hope everybody of you are well versed with this figure of sectorization of the vascular supply. And this is the reason so that you can have an appropriate approach to the lower uterine segment. That is why you need to separate this bladder down, so that you can approach this segment and take this on vessel or tie a tourniquet or tie a transverse beeline suture in an appropriate manner, so as to control the bleeding and the life. So let's see this picture. If you see this picture, let me take a pointer. Okay, you see this picture. This is a common picture when we encounter a lot of adhesions. We have opened the rectus sheath, and now this all over is the rectus muscle. This is the lower pubic symphysis side. This is the upper part. Now, anatomically, you have to think what you can encounter underneath, right? So adhesions are going to till the upper uterine segment. No, it's not going to be that. It's going to be in the midline and in the lower part. Where could be the bladder? So this will be the bladder side, where the bladder will be densely adherent. So you have anticipated that this part will be adherent. So now you have to go above these adhesions, and you have to come from lateral to medial side to approach to these adhesions, so that you can have a clear plane in between these two adhesions. The one more thing you need to understand, what is the location of the inferior epigastric artery, which need to be ligated if you are cutting over the this rectus muscle. Otherwise, this inferior epigastric vessels are going to bleed, and post-operatively, you can encounter the rectus sheath hematoma, or the patient can present as a bladder flap hematomas. So the principle of tackling adhesion is go layer-wise, counter traction, cut the dense adhesions. Peritoneum should be opened as high as possible, reflect bladder peritoneum carefully, and remain away from the vital organs. So let's watch this video of where we are going as high as possible to tackle these adhesions. So here we are. Good traction, even once you are opening a skin subcutaneous tissue, a good traction should be given, and you can use freely. Now, the rectus sheath has cut. You create a space in between the rectus muscle and the rectus sheath, and go as high as possible in an adhesion-free area, because upper part of the abdomen is not going to have adhesions. If you see, we have to keep this rectus sheath direction at the angle of the 45 degree, so as to clearly delineate the plane in between. Make a space, and as soon as you go up, you will find one yellow area, which is a preperitoneal fat in that area, and that is the site of the entry. Never try to go with the preperitoneal fat at that place. Slightly dissect beyond that, so that adequate space of adhesion-free entry can be obtained. You can lift up though the rectus muscle with the back of forceps to see how much are the adhesions. Then this adhesion is also important to dissect in the lower part. Rectus muscle should also be separated along with medalis. And here you can see the yellow areas. This is the site of the bladder, which is densely adherent. But always you can get a small yellow area above from where you have to enter, and a small yellow area to enter in the preperitoneal area of the bladder. So you insinuate your finger and do the clamping and cutting along the edge of your fingers. So you can see the down area. This is a preperitoneal area near the bladder. So you can just stretch with 2 fingers this area, and you can have one window down, one window below, which can be opened very nicely. So you insinuate your finger, join the finger from above, and then just put in a finger and a clamp to create a space. See, always remember that you have to remove this rectus muscle. Otherwise, you will not have an adequate space to take out the baby, and then you will give a T over the uteruses. So please remember that these adhesions need to be broken beforehand and go to the upper part as high as possible to deal with this adhesion. So we are cutting over the rectus adhesions over the uterus. So we have created a good space, and now this is the area of the bladder. Bladder has been separated. We have a good lower uterine segment, and my incision is going to be only on the lower segment, uterine segment, and we can have a stitching after that. So this is the way you approach by going as high as possible and from lateral to medial. Now coming to the principles of dissecting the bladder. So in a bladder, whenever it is densely adherent like this, try to open the parametrial space. And how you do that? You give a round ligament traction by holding it with the Babcock's forceps and then cutting over the anterior leaf of the broad ligament, and then create a retrovesical bypass by putting up your finger from the parametrial space from lateral to medial side in a retrovesical space, because there is an adhesion only at the level of the scar, not below that. So you have to put your finger below and then come. I will show you in a minute's time. So this is another video where we are going in a previous to Caesarean section. We are going now. I will not try in between to find out the space. I will go as high as possible. The yellow area is seen. I am going slightly above that yellow area so that adequate space can be obtained. And remember that the posterior rectus sheath is there in the upper part to guard the organs in between. Below the arcuate line, there is no posterior rectus sheath. That is why if you try to enter from that area, you are likely to injure the things. Now we are separating the lower part of the rectus, and this yellow area you can see here. You put in a finger and extend in a cephalocaudal direction, and this is a preperitoneal area of near in front of the bladder. Then you insinuate your finger and cut boldly these muscles and the peritoneum. There is no problem, and an adequate space is obtained. Now this is a bladder totally adherent. You can see, hold the round ligament. This is a Pelusi maneuver, and then hold the broad ligament peritoneum. Just lift it up, give an incision nick with the help of the scissors, and give a 0.5. This is a slow movement. I have done the editing so that you can easily understand. Put in a finger, and then from lateral to medial side, from down to above, from lateral to medial side. Remember, down to below, cut over it. There is no problem. This is a thin peritoneum, and now your whole bladder will go down. Similarly, come from the other side. You can give a nick on both the side and then come from both the fingers together, which is actually a Pelusi maneuver. So now again on the other side, hold the round ligament and then give a nick over the broad ligament. Put in a finger from lateral to medial side, come from down to below, and your whole bladder is separated so nicely so that you are going to give incision only on the lower uterine segment. So you can see how nicely we are putting up a finger, and then whole lower uterine segment is in front of you. You can see the uterine artery also. Give 3 centimeters below your utrovesical fold of peritoneum, and your life is easy if any amount of bleeding occurs. This is a conventional way of separating the bladder. Here you always have to remember, similarly, we are giving an incision extending on both the sides. And now, don't try to give a blunt dissection. Please go with the sharp dissection in this area. Give a tractal direction. Hold nicely, you can separate the bladder. But many a time this happens once you are separating the bladder. What will happen? The scar will give way as in this case, now you have to deliver the baby without completely separating the bladder. So no problem. We can separate this bladder later on also, because lower uterine segment should be clearly visible so as to take good 2 layers suturing of the uterus whenever needed, right? So we'll just deliver. Now you can see the traction and the counter traction is a way for your dissection. With ellipsis, we are holding the lower uterine segment and the bladder peritoneum is being pulled up. Even you can hold the bladder, there is no problem. Then you give a sharp incision over this peritoneum towards the uterus, right? You can give a nick, insert a blade, hole inside, and then cut and then push, cut and push. Have a good traction over the lower uterine segment in this way. Always separate the peritoneum near the angle area. The advantage of Pelosi maneuver is that you don't have to do this procedure if you have done the broad ligament incision, as at the angle you will never find a peritoneum in this case, right? So you just go till the angles should be clear. And why you need to have an angle clear of peritoneum? If you need to have a uterine artery ligation, you need to give a transverse Beeline suture for controlling the bleeding of the sector 2, that is a lower uterine segment. A good exposure of the lower uterine segment have to be there while that's why the separation of the bladder is key for any surgery, any cesarean section. Always anticipate that this patient can bleed, right? So if this patient can bleed, you have to have a bladder nicely separated. Otherwise, even the bleeding is there, these areas always get full with the blood, and then you also panic, and in those panic you can get. Whenever you have a doubt, please do a methylene blue test at the end of the surgery. And even if you are not satisfied, please keep the catheter for 5 to 7 days, not only for a 48 hours that I have done a cesarean and a dense adhesion, so I will keep the catheter only for a 48 hours. No, bladder is a forgiving organ, yes, but you have to keep it decompressed for a long time. So in case of suspicion, keep it for a long time. There is no role of keeping the catheter for 48 hours in cases of suspicion. Always remember, bladder is forgiving, but bowel is never forgiving. So small amount of holes, the bladder will heal, but the bowel will never heal. So this is a dictum of the surgery, that all bowel injuries should be repaired in a very nice manner. Anyways, any injury should be repaired in a nice manner. So you have to separate till the angles. So this is a concluding slide that the technique can be modified according to clinical situation and expertise. Seek the upper abdominal entry whenever you are dealing with the previous section. Don't worry, don't try to stretch if you have got a small space and then you and your assistant are pulling here and there and then cutting. No. That is not. Go with the upper abdominal entry and take a good area and then cut. Explore the parametrial, medial, paravesical and retrovesical spaces to achieve a complete bladder. Do methylene blue test at the end whenever in doubt, and call for assistance whenever it is needed. So if you want to observe the live Pelosi maneuver in my OT, you all are welcome. You can talk to us. And this is one maneuver which I love, and other obstetrical procedure also. Thank you all for your patient hearing.
So, thank you, ma'am. It was a very good talk. Your key points were anticipation of the problem, that is the crux of the solution actually, and the sites of adhesions according to you have to work definitely. Although more of a bladder adhesions, and that is faced by most of us while doing a previous section cases or previous abdominal surgery cases. But other additions, if the audience have other questions also, I think ma'am is ready to answer that too. And question answer session is open for a while, definitely. Ma'am, your pararectal, the parametrial approach of the lateral dissection and the sharp dissection, as you have shown in your videos, were excellent, definitely.
So actually, somebody has asked whether to use Pelosi maneuver routinely or not routinely. See, at the time of the emergency, you are not going to try on a new procedures. वहां तो उसी वक्त आपका थॉट ब्लॉक हो रखा है व्हाट यू नॉट गोइंग टू ट्राई सो दीज आर अ वेरी नाइस प्रोसीजर यू कैन डू routinely also unless until you have a guts to hold that round ligament and give a nick, and I can promise you, you can just think of my video and just open it. Nothing will happen. 100% guarantee from my side.
So,
Thank
you, ma'am.
Video, Aruna.
Yes, ma'am.
And very good take-home messages. Yeah, very good take-home messages. I said, and excellent video. Yeah, right.
Thank you, ma'am.
The
Thank you,
coordinators, please look at the time.
Yeah,
Aruna,
thank
please
you,
make
ma'am.
sure that you
Yeah,
answer
ma'am,
all
we
the
are-
questions in
yeah.
the chat box. Yeah.
And please don't worry, the recordings will be available. So please focus on what is being talked about. Thank you all the chairpersons for session 1. It was excellent having you. If more questions need to be answered, please take care of the chat box. We'll go on to session 2. Can I please invite the chairpersons for the next session? Yeah, we'll start with Dr. Megha, who's a senior consultant at Park Hospital, Jaipur, and ma'am is national coordinator of the FOGSI MTP committee. She has been an active member of the Jaipur and the Rajasthan OBG Society in holding various posts for them. Jyoti, Megha ma'am, welcome. Dr. Rashmi, she's a senior obstetrician in Noida with more than 4 decades of experience. Rashmi ma'am.
Thank you so much.
Yeah, thank you, ma'am.
Thank you
And
so
Dr.
much.
Jyoti.
Hello.
Thank you.
Good afternoon.
Good afternoon, ma'am.
Good
Dr.
evening.
Jyoti, ma'am, I hope you have joined. She's professor and head department of OBG at Ramaiah Medical College, Bangalore.
Yeah, here.
Yeah, thank you, ma'am. Dr. Megha, can I please request you to call upon the first speaker for the second session?
Yeah, it's my pleasure to be a part of ICOG, and thank you so much, Pradeep Tambe sir, for giving me this opportunity. And I'll take this opportunity to invite our first speaker for the session 2, that is Dr. Atul Ganatra sir. He's a consultant OBGY and an gynecological endoscopist. He's a director and IVF consultant at Progeny IVF Center. He's a director at Nantara Nursing Home. Sir is being the president of IAGE in 2024, a general secretary of IAGE 22-23. Sir was a vice president FOGSI West Zone in 2021, chairperson of MTP committee FOGSI from 12 to 2014. Sir has been a vice president of IMM Mulund, member of managing committee of MOGS, and member of medical advisory committee FPI. We welcome you, sir, and we are looking forward to listen to you.
I'm not able to see Dr. Atul.
Sir has not joined yet, ma'am.
If Dr. Ganatra is not there, maybe you can move with the
Yes, ma'am. We will.
Dr. Saha is here.
Yeah, we'll move to the second one. Till that time, we'll contact Dr. Atul.
And someone, please.
Yeah.
That will be a good idea.
Yeah, okay. Saha sir, are you ready, please? Can we? Okay, sir. Rashmi ma'am, can you please introduce Dr. Saha?
Okay, Dr. Pradeep Saha. He is professor, Department of FOGSI Gynaecology, this is from Chandigarh, President Association of Gynae Oncologists of India, and this Chandigarh chapter. Lots of publications, research and presentation, 120 publications in international and national journals, written several book chapters, oh my God, and total citations are 1440, this thing, and member of editorial boards, and a reviewer for several international journals. So he has special interest in preventive oncology, hypertensive disorders of pregnancy, and morbidly adherent placenta. And special contribution in placenta accreta spectrum. So he will be speaking on LSCS in PAS. So, Dr. Saha, please.
Thank you so much for your kind introduction. I really thanks the ICOG and the organizing committee, especially Dr. Manju, Dr. Mitra ma'am for giving this opportunity. As you know that surgery for placenta accreta spectrum remains one of the most challenging, and it's a complex obstetric procedure. And as you know that despite significant advancements in the diagnosis as well as the management, the complications happen, and most of the time it's a massive hemorrhage, and there are bladder injuries and prolonged ICU stay, and sometimes yes, there can be a mishap. So today I'm pleased to share our experience, that is the bladder first approach, that is the strategy which we basically have been practicing for several years now, and we have published in international journal as well. So I would just like to discuss about the philosophy of that particular surgical approach, what is the rationale, what is the surgical steps, and what is the outcome. So So as you know that placenta accreta already mentioned a significant morbidity as well as mortality, specifically in a developing country like India. And the disease, which was very rare before 1970, has become very common. So if you look at this particular graph, you can easily appreciate that as the incidence of cesarean section has increased, there is an increased incidence of placenta accreta spectrum. So between 1960 to 2002, the incidence has increased from 1 in 30,000 pregnancies to 1 in 500 deliveries. This constitutes almost 60-fold increase in a matter of 5 decades. Now, if you look at this statistic which I have been taken from the from our department, from 2016 till 2025, more than 500 peripartum hysterectomy has been done because of placenta accreta spectrum. This does not include the patient who did not require hysterectomy or conservative approach. It's a huge number. If you look at this 2024, the incident has reduced. It is not that like that, because most of the cases now we are doing the conservative surgery. So this statistics does not tell about what, it's only that the hysterectomy that we basically perform. So it's a huge burden of disease, and it's the high incidence could be because of that PGI actually gathered patient from 5 different states and referred to our centers. So if you look at different guidelines, ICOG and then the BJOG, the recently published, and then FIGO, the synthesis of this guideline, you can, if you analyze all these things, one can appreciate that, of course, this patient should be treated in a multidisciplinary team in a tertiary care center. And of course, there has to be an elective procedure rather than the emergency procedure. So there is no doubt about that. And if you look at the different surgical approach for placenta accreta spectrum, there are non-conservative approach, means that primary cesarean hysterectomy after delivery of the baby with placenta in situ, most of the times is preferred. However, there are other approaches as well. One is that is the conservative approach. Among this conservative approach, there can be expectant management, means after delivery of the baby, you leave the placenta in situ and you expect that the placenta will expel on its own, but it takes a very long time and we don't practice. And another approach is the uterine reconstruction and resection and reconstruction. So that's basically one-step conservative approach. And other approach is the triple P procedure, which is mainly originated in the St. George University Hospital, London. So we basically either do the primary cesarean hysterectomy or we do partial resection and reconstruction. So I just focus on these two particular approach. Now, this is very important because you have to look the ultrasound, and this particular score, this based on the ultrasound features, grayscale, as well as the Doppler finding, and some clinical parameter like number of previous cesarean section, as well the relationship of the placenta and internal os. So based on this score, you can give the maximum score of 20. So in our opinion, we have seen that if the score is 10 or less, then you can preserve the uterus. You can go for the one-step conservative approach. If it is more than 10, then probably the patient will require the hysterectomy. If the score is 15 or more, then probably patient can have a massive hemorrhage. You may have to prepare accordingly. Another important thing I like to highlight, because it's a complex surgery, so you have to have the checklist for this kind of surgery apart from WHO checklist for any kind of surgery that we practice. So I'm not going details. Every institute should have their checklist depending on the resource available. So I'm going to quickly go to the bladder first approach in cesarean hysterectomy for placenta accreta spectrum. So the approach we basically follow most of the time. Initially, we used to do hysterectomy, almost 90% of the cases, but gradually for last 1 to 2 years, it has now almost 50 to 50%. Means 50% we can preserve, and 50% of the condition we have to do the hysterectomy. So for some of the steps are same, whether you do the conservative approach or it is a primary hysterectomy. Earlier we used to give general anesthesia, but gradually we have changed from general anesthesia to epidural and spinal anesthesia. However, in some of the condition we have to convert to GA also. We always prefer vertical midline incision, and you have to dissect the bladder flap before delivery. That is very, very important step. Yeah, if you want to do the one-step conservative approach, you have to dissect the bladder first. Otherwise, you can't think of this thing. And then you have to decide your incision. If it is a primary cesarean hysterectomy, you should avoid the placental attachment. So most of the time, we prefer the classical incision, and no attempt is made to remove the placenta. But if you if you want to preserve the uterus, then it will be different approach. So I am going to tell about the primary hysterectomy. So here you are not going to remove the placenta, and you have decided that this patient is not basically qualified for that. Placenta left in situ and hysterectomy with the placenta left in situ you have to approach. So what is the basic philosophy of this bladder first approach? It is basically to achieve the vascular control of the collateral circulation. Means that network of vessels will be there between the uterus, uterovesical peritoneum and the bladder wall prior to ligating the main uterine vessels, that is the uterine arteries. The reason why I am mentioning, because in 2015, the ICOG mentioned that you take care of the uterine first, then you separate the bladder. It is just opposite. So once we publish this article, then they have removed that particular statement. So what is the rationale behind this principle? In our previous experience, what we have understood that even after hysterectomy, there is troublesome bleeding which continues to occur from the bladder surface, mainly from the blood vessels which are traversing between the bladder and the uterus. This is a fairly large area, and continuous oozing, which is difficult to control, results in significant blood loss. So we dissect the bladder in a controlled situation, and unhurried and calm manner, and ligating this vessel prevent hemorrhage. Now, what happens if there is a bleeding and you are in hurry? You don't know what you are actually structure, what is lying beneath it, and the most of the time the complication, mainly the bladder injury, happens at that particular moment of time. So if you separate the bladder, that will help. And also it basically have to, you have to partially fill the bladder to define its superior boundary. That is very, very important. So when I show my videos, I will show the different steps. Just 1 second.
So till this time the sir is starting his videos, I would want all delegates and faculty members to please note, I have put the link of his ICOG masterclass on placenta accreta in the chat box. The entire session was on placenta accreta. So all the theoretical aspects, all the practical aspects which were there in the PPT have been put there. You can go on to that YouTube link of the entire recording. Till that time, sir is starting his videos to highlight only
So in all case, we open the abdomen by midline vertical incision. As I have mentioned, that now we are prefer the epidural anesthesia and spinal, unless you are doing an emergency setup and patient has significant blood loss. Yeah. So just give it to me. please. So this patient was previous 3 cesarean sections, and it was an elective peripartum hysterectomy. And as I have mentioned, it's a midline vertical incision. Before giving anesthesia, we will always put the 3-way Foley's catheter, so that you have to inflate and deflate the bladder to find out the superior limit of the bladder. That is very important. Otherwise, it's very difficult, specifically when the placenta is actually percreta. So in this particular case, you can see that the vessels are almost there, and these are the bridging vessels between the uterovesical fold and the bladder. So these vessels should ligate on both this side. And then we usually prefer the 2-0 silk suture, because it is easily available, low cost. And then you have to ligate both the sides, and you have to cut. Now, sometimes the vessels are small. You can use the bipolar cautery also, although this is earlier videos, so that at that time we use only the silk suture, but nowadays use the bipolar. But if the vessels are bigger vessels, it's better not to do the coagulation, because these vessels are neovascular, new vessels, they devoid of tunica media. So coactive coagulation may not sometimes, it may not work. So, but yes, the bipolar sometimes may work. So these are, you can see, it looks like small, but it's not like that. So you have to be very gentle when you are basically dealing with this particular vessels. And once you have separated the bladder, you have to be very careful and very gentle, and have to be very calm, that you are not going inside the placenta. Otherwise, what will happen? There can be bleeding. So as you can see in this particular case, there is a placenta percreta as per the FIGO classifications grading. This is 3C. So this was going into the parametrum as well. So there is some amount of bleeding in this side. So it happens most of the time. So if there is a bleeding, you just don't do anything. Just press on it with the sponge and then go other side. Then come back about 3 to 5 minutes. The bleeding time is around 3 to 5 minutes. So again, you come back and then you can again start. So suppose you cannot separate this bladder from cephalocaudal direction on midline, then what you have to do, you have to go to the round ligament and open the leaf of the broad ligament, and then come from lateral to medial side. Because sometimes what happens, you may not get space in midline, but you can get the this thing approach from lateral to medial. And over a period of time, what we have decided that is better to separate from lateral to medial than from the cephalocaudal direction in the midline. So in this particular case, we have separated the bladder, and then you have to see the topography, where it is actually where it is going. And this this particular area, you can see that that vessels are going into the left side of the parametrium. So we are just tying on both sides with the silk suture, and then you have to cut in between. So that is very, very important. And partially filled bladder is very, very important, because the reason why I am telling that in our series of 90 cases, when we critically analyzed that bladder injury in 3 cases, we have realized that in 2 cases, the bladder was not filled, because the resident who actually supposed, at that time we used to use that only the simple Foley's catheter, not the 3-way Foley's, because somehow it was not being blocked from below. So the bladder was not distended. So you can see there is amount of bleeding. And then one case, it was an emergency setup. There are lots of bleeding, and we're not able to see anything, and inadvertently injured the bladder. So in this particular case, I think I should go little fast. So the same way, you have to separate the bladder, and we have understood over a period of time, that the amount of bladder separation is inversely proportional to the complications. So if the bladder separation is more, then complication will be less. Complication will be less. If the bladder separation is less, then complication will be more. So that is very, very important. And so yeah, just going back. So in this particular case, we already have taken the round ligament of one side. So I'll just do fast forward. So almost
we are very short of time.
Okay. Then I will. So you have to. We're now basically delivering the baby by classical incision at the fundus. Have to go above the placental attachment. That is very, very important. Otherwise, if there is placenta is involved in your incision, then there can be bleeding. right? So once the baby is delivered, then quickly you have to suture with the number 2 chromic catgut, and then the rest of the approach or rest of the surgical steps as like any other hysterectomy. But then if the patient bleeds, then you have to little fast. But this particular patient, she is not bleeding much. So this is basically a left side tubo ovarian structure, and rest of the steps as like any other hysterectomy. So when you are basically taking the uterines, it is very important to see the ureter also, because ureter can be there, and most of the time this lower segment will be distended as compared to the upper segments once the baby is delivered. So that's the thing. So I will just, this is basically the uterines on the left side. You are almost going into the almost cervicovaginal junction. Our always approach is not to do the total hysterectomy. We always prefer the subtotal hysterectomy. In our experience, what we have found that it usually do not involve the cervix. So that's the basically very important. And total hysterectomy, it takes the more time because
Dr. Saha, I think you are overshooting your time. It is already 1 minute past.
Okay. So you have to check the ureter and the and all the that pedicles and the hemostasis and put the drain. Okay. So next please. So in next videos, I will show the one-step conservative approach. The initial steps are same, and only thing is that after opening the abdomen, you will get some idea after by your previous ultrasound report, that whether you'll be able to conserve the uterus or not. In this particular case, she had a previous to cesarean section, but she's very young, as 28 years. So we are basically separating the bladder from the lower uterine segment as like previous one, and you have to be very gentle. And as you can see that almost the placenta is coming out and only the thin out serosa you can see. This is the bladder, and then you have to completely separate the bladder. That is very important. This is the round ligament on the left side, and it is thin but is vascular. It's very vascular in fact. So the same way you have to separate the bladder from the parametrium as well as from the on the midline, and all vessels have to be either ligate or have to cauterize with bipolar, and then you cut. And you can see there is a normal myometrium over there, because in previous patient there was no myometrium at all above the cervix. So in this particular case, this is going to the parametrium, but this normal myometrium is present in this particular area. So once you know that you will be able to preserve the uterus by checking that 2 centimeters of the myometrium is there above the cervix behind the bladder, and also that it is not involving the more than 50%. So now we are giving incision over the just above the placental attachment where the normal myometrium you can see over there. So the because you can't give the classical incision over here because it is very difficult to resect and to reconstruct. So the same way, so the baby is now delivered, and immediately you have to extrude the uterus. That is very important. And in this particular case, again, you see the posterior aspect of the uterus because you haven't seen the posterior aspect and other structures since you have not extruded the uterus. So in this particular case, you can see that we are taking the vessels of colpouterine vessels on right side, and then the colpouterine vessels in the midline, and after that we are going to take the colpouterine vessels of the left side. So you have to take the 3 colpouterine vessels, which are actually branches of the vaginal artery, which in turns branches of the anterior division of the intra-iliac artery. Now again, in this particular case, we are taking the uterines as well, because we feel it is very vascular, so it is taking the uterines also and the descending cervical on right side. So after you have taken all these vessels, 3 colpouterine and 2 uterines, and then sometime descending cervical, then you have to cut the that part of the uterus which is attached. So this is starting from the right side and going down, and you have to make sure that you should not cut your sutures. That is very important. Yeah. So you have already removed the defective portion, and you are taking the sutures And you may have to take another sutures also at the base. That is very, very important. Sometimes it happens
Sir,
that...
we have overshooted the time by more than 5 minutes. We have been told to.
Okay.
Yes,
So
sir.
I'll just conclude.
Please wind up,
This
sir.
is almost 10 centimeter of the defective part we have removed, adherent part. So yes, here is my lecture. Yes,
Ma'am, we will have to wind up because...
Yeah. 2 minutes more.
Sir, 2 minutes.
Thank you so much, Dr. Pradeep. It was excellent. And one important thing is you have to make sure that the whole checklist is fulfilled. Otherwise, don't ever try to do all those things. And thank you so much, Prateek sir and Sheila madam and whole of ICOG team for inviting me to such a wonderful listening. So I think Dr. He is there, no? Atul
Yes,
Ganatra?
ma'am. Yes, ma'am. Dr. Atul is there. I would request Dr. Jyoti or Dr. Megha. We had already given his introduction. Probably he was just not able to join at that moment. He's there. He's been there with us since.
At the
Atul,
outset,
sir.
I thank ICOG for inviting me to chair this session. And I thank Dr. Pratik sir also. And Dr. Atul Ganatra is a consulting obstetrician and gynecologist, renowned person. We all know him. And is a gynecological endoscopist and robotic surgeon from Fortis Hospital, past vice president of FOGSI, past president of IAGE, director department of OBG, Fortis Hospital, Mulund, and past chairperson of FOGSI of MTP committee. We welcome you, sir.
Thank you very much. I hope I'm heard.
Yes, sir.
Thank you, ICOG. Thank you, Dr. Mitra Saxena, Dr. Sheila Mane, my teacher in MBBS, and the entire team for inviting me here. The time allotted to me is 15 minutes, so I'm going to be very brief in my presentation. This is something I got last month from one of my patients. For you, this may be a part of your profession, but for me, it was the biggest dream. During my pregnancy, you not only handled my delivery safely, but also removed the fibroids with so much care and confidence. Because of you, I was able to give birth to a beautiful girl. Today, both my baby and I are healthy. She sent me a picture and she sent me this card. We removed a 10 centimeter cervical fibroid. When I did a PV the first time she came to us because she was referred and refused at 3 places, I could only feel a ball. And that was this large cervical fibroid. And we've done many such cases, but this was the best gift that I received. These are some other cases. Now, this is another patient with a large cervical fibroid. Now, I think doing a myomectomy, every gynecologist knows. I don't think we need to teach a gynecologist myomectomy. I just need to teach them one thing. This is something that I need to actually teach them. This is internal iliac ligation. I hope you all can see the video clearly. Go as
Yes,
lateral
sir, it's clear. It's clear, sir.
I mean, between the round ligament and the fallopian tube. I'm going to do one case on Monday, a placenta accreta. I hope I can do a good recording, and I will share it on the ICOG site. Am I heard?
Yes, sir.
Yes, sir.
Yes,
Hello?
sir. You are clearly heard, sir, and the video is visible.
You need 4 Devers forceps, 1 mixer, and a sponge holder and a good assistant. All you need to do is dissect bluntly with either a sponge holder or a blunt suction. You can first identify the ureter. That is the ureter you can see here. That is the ureter. Once you've identified the ureter, the rest of the thing is very easy. External iliac is a superior organ. Internal iliac is a little deeper. All you need to do is put a mixer inside. Create a space, keeping the area wet. Don't let it dry. Somebody keeps sprinkling saline there. And you pass a mixture. Pass a cervical through this. The ureter should be in your vision at all times. That's it. I think if we've done this much, the rest of it is as simple as for every gynecologist. So the basic rule, first, do no harm, follow evidence, false evidence when it appears real. So we need to be careful, fear that false evidence. So Victor Bonney said it is tempting for the adventurous and sympathetic surgeon to condense the operation of Caesarean section and myomectomy into one undertaking, so to save the patient's ordeal of the second admission to the hospital. This kindly and misguided policy we heartily deprecate. He said it's not safe. Caesarean myomectomy can have these following threatening complications: massive blood loss, peripartum hysterectomy, blood transfusion, admission to the ICU, adhesion formation, a scar integrity, a doubtful scar integrity in the subsequent pregnancy, but I don't think any of these things happen. We've delivered many, many patients like this. Case 1, primary 30 weeks, 30 years, 6 weeks pregnancy. USG suggestive of a 6 weeks intrauterine pregnancy with a large lower segment stroke cervical fibroid. Patient was advised termination of pregnancy. You can see this is when she was about 34 weeks and she started leaking. We had to put a stitch. Now, remember that usual classical incision that I took, I couldn't find the lower segment. I took another incision here, and can you see this? This is the cervix. The cervix was right up in the abdomen because of the cervical fibroid. Now, unfortunately, this patient did not give consent for a cesarean section. So all we did is delivered the baby, and this was the ultimate picture that you see here. And this was the cervical fibroid. The cervix was in the abdomen because of the fibroid. This was a transverse lie. We delivered the baby. And because of negative consent, we did not go ahead and do a myomectomy. Otherwise, this was a straightforward myomectomy. But this is one of our earlier cases in the 90s. Today, adequate counseling, adequate consent is taken. We prepare the patient. Of course, if she does not want a myomectomy, we don't force her, but a lot of them do. And many of us now at Fortis Hospital come across patients with fibroids, which are so placed in such a situation that you cannot deliver the baby without that. Another case, Mrs. X, 31 years of age, came to us for a second opinion. Case of primary infertility. She had 6 to 7 fibroids, advised myomectomy and then IVF. This is exactly how the fibroids look. Now, fortunately, all these fibroids were type 5 or type 6 fibroids. I said, let's do 3 months. If we don't conceive, we will go ahead and do a myomectomy. By God's grace, in the second month, she conceived. Now, she kept complaining of pain right through. The urologist saw her. They did a lot of tests. She had UTI, but her pain wouldn't settle. And we knew she had fibroids, but we were not aware of the fact that one of her fibroids had undergone torsion. She is a very big builder's daughter-in-law. We took adequate consent. We delivered the baby first, did internal ligation, and then removed all the fibroids. So this is possible. I don't think there is a lot of magic in removing the fibroids. Everybody does myomectomies day in and day out. Here we removed about 7 fibroids. So the trick is how to avoid the bleeding. And if there is any doubt in your mind of the myomas are deep-seated, as you can see here, all you need to do is internal ligation. And mind you, the major fear that once we do an internal ligation, patient will not conceive again. That does not happen. This patient has come back to me the second time and delivered, and we have many, many such cases. Should we perform myomectomy during a cesarean section? Tricks. Myomectomy as cesarean section is a safe option. This study from Turkey said it is safe. The American college said not safe. The European college, the RCOG also says not safe. A case series of 8 myomas. I think I should also publish my data. We have a series of another more than 28 cases. Caesarean myomectomy is a safe and effective procedure well done by skilled surgeons. You should be confident that you can do it and you will be able to do it. It results in no significant bleeding post-operatively. And with the advent of barbed sutures, I think doing a myomectomy laparoscopically or open has become a lot easier. It also relieves symptoms related with fibroids and time, and money-saving procedure that avoids interval myomectomy. Thus preserves the uterus for future pregnancy. One thing that I was watching Dr. Saha operate, and we use a lot of ligashore when we do Accreta or when we do a myomectomy. Then you don't have to do that meticulous suturing of the vascular, the neovasculature that is there. The clinical approach, traditional view against removing fibroids, and there is evolving evidence that in strictly selected cases, or if you have a good facility, a multidisciplinary team, you can go ahead. In the past, we used to do it only in fibroids which came in our way. Lower segment fibroid, especially in the anterior wall, cervical fibroids, but now we do offer it to our patients. If they are significant, if they are 2 and 3 centimeter fibroids, we don't bother about it. Factors to avoid: deeply embedded or large multimyoma clusters near major blood vessels or corneal regions are typically left alone to prevent massive hemorrhage. Again, this is something that we do now with experience, but I think this is not the message that I would want to convey. Doing nothing is easy, and that's why many people do it. But I think it is just a question of time that you progress. All of us have done myomectomies. All you need to do is get used to doing the internal iliac. It takes only 3 minutes to do one internal iliac on one side. You just need the right approach and the right instruments. Number 2, leave it with a uterine artery ligation, and it is said that these myomas will shrink. It will minimize the risk of future surgery, lactation, puerperium, and reduce the size. So that is another way you can do it. Just go ahead and electively ligate the uterine arteries. Removal at cesarean myomectomy, it avoids repeat surgery, relieves symptoms, reduces postpartum complications, saves cost and time. Removal of pedunculated fibroid only, removal of pedunculated anterior wall fibroid, removal of all anterior wall fibroids, removal of all fibroids, fibroids of more than 5 centimeters, selective removal. I think these are all your options. The main principle: experience and a skilled person, multidisciplinary team, good anesthetist backup, good blood backup, and somebody to support you or help you when you're doing the internal iliac, at least in the initial stages. Well-equipped theaters, better anesthesia and available blood, full consent and counseling, high hemoglobin, size and site of the myoma, and a good assistant is very, very important. To summarize, it is not absolutely contraindicated. Decision depends on location, size, number, preoperative counseling and consent, individualized management in a tertiary setup. Finally, friends, know yourself. Know thyself. You should know whether you can do it. If you can do it, offer it to your patient. Otherwise, let it be. And it is not necessarily the amount of time you spent at practice that counts. It is what you put into practice. Thank you very much for patient sharing.
Thank you, Dr. Atul. That was really nice. I just have a question. What is the role of vasopressin? We don't use it at all for cesarean myomectomy instead of...
If you use it in a lap myomectomy or a non-pregnant patient's myomectomy, use it in a pregnant patient. There is no harm. I use it regularly in all my patients, even if it is a infection.
Because it really works magic for my other gynec myomectomies. That's why I was
Yeah, absolutely.
Non-pregnant.
Like somebody said on the message, mapping of the fibroids in pregnancy is not very easy unless the patient has come to 6 weeks or 7 weeks. When the fibroid, I mean, for example, these patients come to us at 28 weeks and 30 weeks sometimes. They don't come to us very early unless they are suggested that you get a myomectomy, MTP done. So mapping is difficult unless the patient has been seen by you in the earlier stages. And the best way to map is to do MRI, because that is allowed in pregnancy. So that otherwise, doing a decent ultrasound is good enough. Vasopressin is very, very safe in pregnancy at Caesarean section. Please go ahead and use it. Just tell your anesthetist that you're using it. And if possible, use the Sanket Prasad needle. It will tell you if there is any blood in it at all. That is another way of doing it. 1 ampule in 200 ml saline, that's about 0.4 to 0.5 units. If you have more fibroids, you can take 400 ml saline in 2 ampules. Extremely safe. And for those who want to do it, I think a ligashore is a blessing in a situation like this, especially when you're removing the bed of the myoma. Just, you can make your vasopressin, nick after the vasopressin. Usually cautery doesn't work because you put so much of saline. You may have to cut with a scissors. You use a myoma screw to hold it. When you come to the base, just apply ligashore and seal it. You won't have to do much suturing as well. And use barbed sutures, absolutely safe, and put interseed on top.
Thank you.
Can I make a comment? Can I make a comment, Dr. Ashwath here?
Ashwath, yes, sure.
Nothing about vasopressin. Now I have a patient in the referred from periphery who Caesarean myomectomy was done. Vasopressin was indicated, patient went in for cardiac arrest.
That's the
So
worry.
she is just
That's
fighting for the because what sir told is correct. You have to, because uterus is very vascular. You have to, because it's the first time I am seeing actually in the periphery. I feel that either they have not used the correct concentration, I don't know, or they would have injected into a vessel, because it's a very vascular uterus. It's a wonderful drug during lap myomectomy and all these things. Wonderful drug. I feel that in Caesarean myomectomy, it should be used with caution. So we can use ligatures, like you can ligate a tourniquet around the lower segment. Okay, make 2 holes in the broad ligament, take a Foley's catheter, take it around, tie it tightly, do the myomectomy and suture it properly, and then release it. And proper indications for myomectomy should be taken care actually. Don't do myomectomy, try to do in all cases. So if it is in the, like sir has told, if it is in the incision site or in the lower segment, or so certain indications are there.
For time. I know.
Okay, no problem.
Excellent, but
I just heard, but I just experienced, because it is, I wanted to share it because that patient is lying in my ICU now. That is very important.
Ashwath,
that is
if
why.
you use
So
the
people,
Sanket Prasad needle, this won't happen.
Sir, Sanket Prasad needle is necessary only for laparoscopic myomectomy, because here you can use a normal syringe. Sanket, in laparoscopy, the problem in laparoscopy is that when it's a long needle, you may not be able to see the blood coming into it. Here it is very simple, because here you can use a normal syringe, you will easily see
and
the
aspirate
blood.
every time you are planning to
aspirate, but Sanket with that needle for a normal Caesarean myomectomy, it will be a long needle that it has to aspirate, cumbersome, but you have it, use it. It's a very nice innovation made by Dr. Sanket Prasad. Okay.
Yeah, but only a simple syringe and needle would be good enough. Like
Good
for
enough.
open
And even if you want to use, you can use a varus needle also. If you want to push it, varus needle or a spinal needle. If it is not going inside, spinal needle can be also used to push it. Okay, these are things.
Thank you, sir. Thank you. I would request the chairpersons to please thank the speakers and the faculty for discussion.
Thank you very much.
Thank you so much, Dr. Atul. Excellent presentation as always. I usually prefer not to miss any of the presentations. And the same with Dr. Pradeep Saha. Thank you so much.
Thank you all the chairpersons also and the speakers. Thank you. We'll move on to the third session. I would hand over to Dr. Nivedita to invite the moderators for our panel.
Okay, thank you, Ashima. Already we are 15 minutes late. We'll try to make up in this session. So we have next a very engaging panel discussion on the topic tackling on-table complication during complex Caesarean sections. And to drive this engaging discussion, we have none other than Dr. Parikshit Tank and Dr. Surekha Taide. Parikshit Tank, sir, is consultant at Ashwini Maternity Hospital, Mumbai. He's been practicing IVF for the last 4 decades. And notably, he is a Kamini Rao Oration winner in 2012 with 100 peer-reviewed publication in Index Journal. So, sir will be joining us in a while. Surekha ma'am, she's a phenomenal personality, a professor at Savangi, Wardha. She was the ex-chairperson of Clinical Research Committee of FOGSI, and madam is on editorial board of various journals, and she is a winner of many awards and credits. Welcome, ma'am. Now, moving with our expert and esteemed panelist, starting from Dr. Ashwath. He is teacher of teachers, coming from Jubilee Mission Hospital, professor in Thrissur, Kerala. Welcome, sir. We are eager to listen.
Thank you.
Dr. Shashilata Kabra, madam. She is specialist and professor in Delhi Health Services. Welcome, ma'am. And she is well renowned for her internal artery ligation and lots of immense work she has done. Dr. Ashwin Bachani, sir is professor and head at Medical College in Surat and past president of Surat Obstetrics Gynaecology Society. Sir has lots of publication in national and international journal. Welcome, sir.
Thank you.
Thank you, sir. Dr. Deepak Desai. Yes, sir is consultant at Virar Maternity Nursing Home, and he is known for his extraperitoneal Caesarean section. So he has contributed immensely to the field of obstetric gynecology last 44 years. and invited faculty in many international conferences for the work he has done in extraperitoneal Caesarean section. Thank you, sir, for taking India a long way in that. Dr. Kiranmai Devineni, she is the chairperson of FOGSI No to Violence Against Women Committee and currently serving as professor at Government Medical College in Telangana and a postgraduate teacher for last 24 years. Madam has also been Kamini Rao Orator in 2013 and she has immense awards and research papers to her credit. Welcome, ma'am. Dr. Indra Palo, Madam is a professor in Berhampur Medical College and a huge academician. Welcome, ma'am. Dr. Uma Pandey, she's another clinician scientist we have joining in from BHU, IMS BHU. Madam is a professor and she is the principal investigator of Champion Trial, which is published in NEJM. Welcome, ma'am. And Dr. Promila Malik, she has done her post-graduation from All India Institute, New Delhi. Madam is past president of Gurgaon Obstetrics Gynaecology Society and more than 4 decades of contribution in the field of Obstetrics. Welcome, ma'am.
Shreya, please unmute all the panelists and mute everyone else.
Over to you, Surekha, ma'am.
So am I audible?
Yes, ma'am. Yes, ma'am.
Thank you very much, Dr. Nivedita. And at the outset, I would like to thank ICOG, Dr. Sheila Mane, Dr. Mitra Saxena, my dear friend, Dr. Manjupuri, another my dear friend. And as you can see, so dear Dr. Mitra is to me that when I was writing the panelist name, on its own, Dr. Mitra's name is also got added to it. So, madam, you're there always near my heart. So, as you can see, moderators, Dr. Parikshit will be joining soon, and I have such huge academicians with me that I'm truly blessed, and I'm sure that this panel will be a huge success with the inputs from such great people who are all there with me here. So we do know that the fascinating Caesarean section, it is so fascinating to watch also, it is fascinating to do also, and everybody of us is performing this Caesarean section in and out. And we are, if we don't do one surgery a single day, if we miss, then we feel something is being huge is being missed in the life. So that how fascinating the Caesarean section is. And of course, there are various factors which dictate unpredictability in Caesarean sections, like dense adhesions if there is a previous surgical history. Technical challenges are there if there is a deeply engaged head, and various complex extraction requirements are there. If there is a thin uterine segment and susceptibility is there either for some injury or rupture, or if there is some urgency and you really are doing it very fast for some reason, then these are the things where you could have unpredictability and you may have some grave intraoperative complications. And you could have tears 4 to 8% of time. You could have PPH, sometimes 4% nowadays it has reduced, but still. And you could have a bladder injury or bowel injury. Ureteric injury is quite rare, but still there is a possibility in case of, a certain situation. So extraction challenges trigger these kind of collateral trauma, and that is what we are going to discuss today. So we are going to talk about some techniques which may lead to trauma. We are going to talk about tears, ligament tears. You are going to talk of broad ligament trauma. So we have this a case-based discussion. We are having 4 cases, and I request the panelists to be, brief and stick to the practical points so that our audience benefits. So here we are, we are having this third gravida who has had 2 previous Caesarean sections, and she is 38 weeks of gestation. We are doing a Caesarean section for her third one. Now, when opening the utrovesical fold, because of dense adhesions, what we see suddenly there is a clear fluid noted. So now we being so, experienced, we realize that something is wrong because maybe the Foley's catheter has popped out or the clear fluid has given you some indication. And as rightly said, yesterday Dr. Mitra was saying that a good obstetrician always has one eye on the screen, which is telling the parameters, and another eye should be on the Foley's catheter. So we looked at the Foley's, and the urine is blood stained. So my question to the panelists here now, if we can. So this is how it happened. Because of the high bladder, the dissection was being carried out, and you can see the Foley's has popped out here, and we know now there is a rent. So question is, of course, there are these problems, the bladder base, the LUS and isthmus directly abutting on the scar, the trigone area, so precarious, proximity to the upper part of the vagina. So keeping all these things in action, first question to the panelists. Do you want to continue the extraction first or execute immediate bladder repair? So what do you want to do first? Second question, do you want to do the repair yourself? Do you want the urologist to be there? And of course, later on, we'd like to know what is the ideal method. So first question first, what do you do first, Dr. Ashwath?
So first you have to identify that it is a bladder injury. You have seen the catheter, but as the baby has not been taken out, you will not waste time. You know that you have gone into the bladder, so you know the base, it's a bladder. So you go above that and first complete the cesarean, actually take out the baby. Once you have taken out the baby, then and the placenta, then you will see for the bladder injury. Then you slowly see for the bladder injury.
Dr.
See
Ashwin.
that.
Yeah.
Yes.
Dr. Ashwin, would you like to do this repair yourself? Do you like to bring in the surgeon, urologist? What do you think?
Usually, I do
Dr.
the repair
Ashwin?
myself.
Yes. Hello.
Yes.
Hello. Yes, if it is simple clear-cut bladder rent, particularly in the dome, not involving this trigone area or near to the ureter, then most of the gynecologists can repair it. So there are no clear-cut demarcation who should repair the bladder during Caesarean section bladder injury. Personally speaking, with good experience, double layer closure in the upper part injury, that is most of our obstetric
injury.
We'll
come to that. Dr. Kiran Mai, would you like your surgeon to be there along with you for medical legal problems? Do you advise that some surgeon has to be brought in here?
Yeah, I mean, for a plain, simple dome injury of 3 centimeters, I think we can go ahead and do it. And if it is nearer to the trigone, or if the ureters are getting involved, if it is deep down, or if it is something difficult, then definitely you have to involve your urologist.
Otherwise, so I think an experience is very important. If you have seen previously a bladder injury, you may have assisted, the repair. Probably you could do, and of course, a clean cut 3 centimeter rent, not near the trigone. You could do yourself. But if there is I have seen one bladder injury where the baby has itself been delivered out through the bladder. So there's a posterior rent, there's an anterior rent. So if you think that it's an extensive, the dissection may be difficult, the trigone may be nearby, you may need to, put a stent. So these are, I think, indications where the urology consult. Nowadays, even the surgeon, we are having so many urologists available. Yeah. Yes.
If the bladder injury is due to a rupture case or a placenta accreta and you are dissecting, and if it is a very complex kind of thing, it's always better to have a urologist, which appears to be a clean cut while you are doing a Caesarean section due to adhesions or something like that, then maybe 3 centimeters on the dome. That is where you can do it yourself.
So yes, Dr. Pramila, what is the ideal method? Have you done such repairs, and what kind of method of repair do you prefer?
Good evening, everyone. Thank you for inviting me as a panelist, Dr. Mitra, Dr. Manju, and ICOG, Dr. Sheila Mane, and Dr. Pratik. The bladder injury in the dome area, the first important thing is to recognize it intraoperatively, which is very, very important. In this case, it was a clear-cut injury, well recognized. So if it is in the dome, not involving the trigonal area or the posterior wall, then the obstetrician can go ahead with the repair. It's a double layer closure, mucosa and then the serosa. And then we can check the closure, whether it is watertight or not, by instilling the methylene blue through the Foley's catheter, 3-way Foley's catheter, to confirm it whether it is the closure is watertight or not.
Yeah.
And then the post-operatively, we have to keep the catheter for at least 7 days, but if the injury is more, preferably for 14 days also,
Dr.
post-operatively.
Shashi, how many days would you like to do? 7 to 10 days is enough, or would you like, initially we used to keep 14 days, 21 days. What do you think?
7 days, they say it's okay.
We used to keep 10 to 14 days.
So there is a sort of a debate. So usually 7 to 10 days is enough if it's not a complex type of surgery, and if so again per urethral catheter, sometimes we have seen that per abdominal also to the space, so that I have seen many urologists doing. So 2 catheters they are putting. One is to avoid any blockage.
They
If
put
there is
one
a block,
they make a deliberate cystotomy
they
and
make
put a
a block.
catheter.
Yeah. So these are the 2 things, but I think usually a per urethral catheter for a clean cut bladder injury is enough. Now there is a question in the chat box about which suture material.
Vicryl 20, Vicryl 20.
20 Vicryl.
20
Vicryl 20.
even
Or 30.
30. So you can use a 20, you can use a 30. Now Dr. Pratik Tambe has joined. I'm so very happy. But he needs to attend a patient. Anyways, Dr. Pratik, I thought you are sorry.
Sureka madam, even we can use a barb sutures nowadays. Okay.
Yes. Nowadays, barbs are increasing.
Barb sutures, barb sutures are used. Now,
barb
can
suture,
use.
But we don't
For
use
bladder
barb
repair.
suture for bladder injury.
For the mucosa, we would prefer a 20 fine or a
20. After that, you can use a barb
absorbable.
suture.
And for the muscularis, but we haven't used any barb suture till
Barb
date.
sutures are required where we need hemostasis, like in myomectomy, but not in this bladder injury. We use plain Vicryl 20.
Yes.
Not the barb.
So again, I have not.
Can use.
But let us give the message that 20 or 30 delayed absorbable suture.
Yes.
And for the first layer, mucosal layer, 30 delayed absorbable suture, and for muscularis layer, 20 is also okay. And you may have a third layer as well for the peritoneal or for any reinforcement if you want to do. This is how you could go in, and of course this is how you have repaired. So what is important is to separate the uterine. Dr. Deepak want to say something about this, how to separate and how it is important to separate the 2 layers and identify the bladder separately away from the uterine incision. So you have to separate both the layers, and of course if there is a posterior cystotomy and anterior both are there, then you have to suture both the layers, the posterior as well as the anterior, and if required you will have to do a deliberate cystotomy to put a per abdominal drain as well. So this is about the bladder injury. How do you manage in the post-operative period? Any instructions you would like to give to your nurses or to your residents?
The most important thing is that the bladder.
Dr. Ashwath, can we give the chance or opportunity to Dr. Deepak?
See, first of all, regarding that separation of the bladder, if you find a rent in the bladder, say in the fundus, you have to separate the bladder, say go from laterally, you get a window there, you separate the bladder totally from the lower segment, and then suture it in 2 layers, ideally 3, as everybody said, 30 and 20, 910. Regarding
post-operatively, yes.
Post-operatively, you should see that the catheter doesn't get blocked. So,
absolutely.
To tell the sisters, first of all, initially see that the bladder urine output is good. Give enough amount of IV fluids. And other thing is that keep a watch. Even you ask the patient also, if you feel that the urine is not coming out, immediately inform. So that is ideally.
Yeah. So the urometer actually would give you a very good idea. So
and we keep a 3-way Foley. If we need to flush the catheter, if it gets blocked with blood, we preferably keep a 3-way Foley.
And usually would like to measure the urine output also. How will you know that the catheter is blocked if you're not getting a good urine output?
Initially,
half
measured with a urometer. So the message to the audience should be, they should use not the normal Euro bag. They should use the Eurometer Euro bag.
Absolutely.
So and hourly urine output measurement is very important. Whenever the urine output is less, immediately ask your nurse to either first thing flush the catheter, and the flushing is not even, you may have to change the catheter. Okay, sometimes you may have to change the catheter.
That's very important, and the catheter care also is very, very important, so that infection does not transmit through the catheter itself. So that's very important. So we usually ask that that hygiene should be maintained, the catheter care should be taken, and the urometer should be there. So that's very important. Of course, any comments about documentation and communication to the family or the patient here, Dr. Shashilata?
Yeah, we have to tell her that this was the condition, and because of that, because of her previous 2 status, this condition can occur. So for the next pregnancy, she has to be counseled, and we have to write everything. We have to brief everything to the patient and her relative, and we have to mention properly in the notes also. And
So
next time,
so previous to Caesarean section, you should take a prior consent only. That
Yes, antenatal counseling is important, that it could be possible.
Even when you're taking the patient for Caesarean section, in your initial consent, when you're explaining the patient what surgery you're doing, you should talk about that there is a possibility of bladder injury. And if you haven't, then you should mention it in your notes properly that this thing has happened, and that's why the patient may require delayed catheterization for a longer duration time. So that's very, very important. So always suspect in a repeat Caesarean section if you are having a blood-stained urine, or you are having a clear fluid rush is there, then suspect. And if required, you may have to do a methylene blue test also to find out, because intraoperative you do a repair, the outcome is good. If you don't identify, you miss the bladder injury, then the problem starts later on, and that is so always, even medical legally, if you have identified the problem, you have managed the problem, then you are medical legally also safe, and also the outcome of the patient is mandate meticulous tension-free closure. So that when you say tension-free, that's why separating the uterus from the bladder and having an adequate amount of bladder tissue to suture. Omental interposition. Any comments on omental interposition, Dr. Vachani?
If it is complex injury, then of course, yes, simple dome injury doesn't require the omental page. But complex blunt injury, then vascularity is the issue. At that time, omental interposition is very good.
Yeah. So you should think of all these things, and then that is
Dr.
about
Surekha, may I suggest one safeguard to prevent this type of injury? In these cases, if we make an incision higher above from the site of previous Caesarean sections, little higher, 1-2 centimeter, then it will prevent a lot of bladder injuries.
So but in this, sometimes what happens now, people give it very high incision also. So keep an eye on how
very high.
So maybe 1 centimeter, 2 centimeter high, fine. But identifying, your eyes actually should be very well versed with the tissue, how it looks like, and that can give you, an idea where to give an incision and how to it.
Secondly, dissecting from lateral to medial, we should come, if there are dense adhesions in the middle, we should start dissecting from the lateral. The way the
Dr. Deepak has already told about this. So let's go to the next case.
No blunt dissection. No blunt dissection.
No blunt dissection. That is very, very important.
Yes. These two things can safeguard.
So you should use the scissor to dissect, and no blunt dissection should be done.
Yes, always a sharp scissor.
Yes, always a sharp dissection. So let us go to the second case where you have a 4th gravida, and she has previous to LSCS, and she's a placenta previa. You are going for an elective LSCS. Baby is delivered safely. Now you will say, previous to LSS, how did you not diagnose a placenta accreta? There are still patients coming with undiagnosed placenta accreta spectrum syndrome. So this placenta actually fails to separate spontaneously. You give a gentle tug on traction and this triggers torrential bleeding in this patient, and you see that suddenly the whole of the field is full of blood, and within minutes the patient has lost more than the 1800 ml up to 2000 ml of blood pressure is falling, pulse is falling. What is the next step for this patient? Anybody? Dr. Ashwat.
Yes. See, first thing, you exteriorize that uterus. Okay. And one more thing, as the blood 1800 ml and the BP has come down, immediately you have to start the MTP, that is massive transfusion protocol. That means immediately you have to get 1:1.
My first question. Let's go to the first question. Do you want to remove the placenta, or do you want to go for damage control?
Don't. See, first step is that if the placenta is not separating, don't pull on the placenta. And see to it that you have the facilities to operate placenta percreta there. If it is not bleeding and you don't have the
patient is torrentially bleeding.
Torrentially bleeding.
Already open. Dr. Deepak, you want to say something?
Hysterectomy.
Immediate, you have to proceed for hysterectomy. Before that, you have to activate the, along with hysterectomy, you have to activate the MTP. That is the massive transfusion protocol, because both has to go side by side. Okay.
Yes.
Dr. Surekha, I think we have to initiate, of course, abandoning the procedure of removing
Just
the
a minute.
placenta.
Who is speaking here? Dr. Kiran May. Yes, please go ahead. Yeah.
Adding to the points what Dr. Ashwath had said, I mean, activating the MTP and abandoning the procedure of removing the placenta, one more temporizing method or, cutting off the blood supply is the aortic compression.
Very good. Yes,
do the
very
aortic
important.
compression, because we are losing time and she's 80-50 and we have really, she's into class 3 hemorrhage. So class
Dr. Surekha, what? Dr. Surekha, what we
just a minute. Let Dr. Kiran May complete.
Yeah, of course, we have to proceed with hysterectomy, but before proceeding or while, because we can do aortic compression for 60 minutes without any damage happening, the anesthetist can do. So this is one thing. If you use the clamp.
So your comments now, Dr. Shashilata.
Yes, this is what I wanted to say, that we should not make any attempt at removal of placenta, because if we make any attempt on removal of placenta, then a controllable hemorrhage can be turned into a big disaster. So here, what we do is that immediately we ask one assistant, we keep one extra assistant who keeps pressure on the abdominal aorta, and side by side, at the same time, 2 doctors, we perform quick hysterectomy in that case.
Yeah. So I don't know. I mean, somebody was talking about. I heard about
one more point can be added. That is ligature.
Yeah.
And we routinely
can do the window in the broad
ligation.
ligament, because here the massive bleeding already started. If we till up to the completion of the hysterectomy and bladder separation, your patient will be in the irreversible shock. So immediately just put the 2 hole in the broad ligament side by to the cervix and ligate with Foley's catheter. So immediately it will be stop the bleeding, and then you proceed for the bladder separation and hysterectomy.
So rightly said, you have to have some temporizing method, so which can reduce. We cannot halt, but reduce the blood loss. Whether you want to use the clamp on the internal iliac vessel, Dr. Deepak, you are saying no.
No use. And
if by doing an hysterectomy, the bleeding stops, nothing to worry. But if the internal iliac will work only if the central placenta previa is required, only if there is a central placenta previa. If it is not a central placenta previa, I think hysterectomy should do well. And you can ligate local, like colpouterine arteries, then it can be done. And other thing is that if you are doing an hysterectomy, if the bleeding doesn't stop, then you can go for internal iliac. There is no need.
Do you want to take any help from
Surekha, can I make a comment? I need to make. So internal, aortic compression, intra-abdominal aortic compression can be a time saver.
Yes.
So definitely
that has already been spoken, ma'am. That has already been spoken by
so that we need to focus on that, and it should be used. People don't use it. You will buy time.
Thank you. Time till the competent person comes. If you are a competent, you can immediately proceed for hysterectomy. You apply clamps, immediately the bleeding will stop. And if you are compulsory in doing internal iliac, So if it is bleeding still further, you can go for an bilateral.
Yeah. So role of internal ILAC is when if you have done a hysterectomy, still bleeding is there, you could go in for an internal ILAC. And of course now we are talking of uterine arteries. We are talking of the descending branch which may need to be. And of course, is there any role of internal interventional radiology in this patient?
No, patient is unstable. Patient is unstable.
No.
Yes, and shifting to a place, intervention
Shifting
radiology.
and then
She has to
they
be.
all take time.
So you
She
have
has
to
to
be
be
whatever. Yes. Is there role of other, people like a trauma surgeon, a urologist, or any other?
Call whoever is available. Call whoever is
With
available.
massive bladder, massive
All
invasion
for
of placenta on bladder, we
prosthetician
may
is
require
the
a
only answer.
neurosurgeon.
Yes,
Rather, we should keep
the
neurosurgeon
message here
informed.
is, let us give a message here. This single surgeon may not be able to save this patient. Whoever is available, you are the unit in charge, another unit in charge, another professor is available around, and that person has to be there. So even two professors helping you out, and if there is a surgeon
you
or
have
a
to.
urologist, because many a times you find that the placenta has encroached into the bladder, and there may be a problem while doing a hysterectomy. So many times there's a problem. Dr. Deepak, you want to say something here?
So every obstetric patient, you should have a blood cross-match ready, because what happens most of the times, if the bleeding starts and you start getting cross-matching blood and all, it takes a lot of time. So you have to have a cross-match ready, and you have to tie up with a blood bank. So you just give a phone call. About 2-3 bottles should come immediately with even FFPs as well. So
there is a question in the chat box. If you are sitting in the periphery and this thing happens, what to do?
Yes, I can take this question.
Yes, ma'am.
Yeah, in peripheral hospital, well, there is no facility to manage a PAS case. There, if you open the abdomen, please give time. Look at the surface of the uterus and bladder. And most of the time, you are able to recognize that this is the placenta percreta or increta. So please close the abdomen and shift the patient to some other center.
So
I like to say something, Shashi.
With this.
We were saying that you close the abdomen, but you actually now you open in the upper segment, take out the baby, and don't remove the placenta, close the uterus, and go with the patient to the higher center.
But here already the bleeding started.
Yes,
you can do
but
that.
I think the message which Dr. Shashilata wants to give is, before giving an incision in a previous to cesarean section, have a look at the topography.
Yes.
Have a look at the uterus. Is it giving you an indication that this could be a placenta accreta spectrum? So there itself you will get an idea if you are going to land into some problem or torrential bleeding may occur. So I think that having a look, and if angry looking vessels are there, you need to be very careful. Of course, even if you want to do a classical cesarean section, it bleeds
label
quite
it
a
as
lot.
an
It
inoperable
bleeds
cesarean
quite a
section.
lot. Yes. So looking at the topography, looking at the topographic classification, and you have to judge whether you will be able to manage this patient. So if you don't open and shift, that is much better, and doing a classical and you are not able to manage that bleeding
Yes, you
also.
should close it and
that can invite medical legal problems, that I have recognized the placenta percreta on the table, and even then I'm giving a classical incision and doing a half surgery, and now sending the patient with
because
the patch to a
classical
subdivision.
incision also, if you're not having good amount of blood and blood product ready, many a times patient will bleed, and many a times in the periphery.
Save the patient.
We have received such patient.
Better to not open, close the and shift. That would be a much better message than doing a classical, removing a baby, and doing a half cooked surgery and landing into a situation and then shifting the patient. So I think
Surekha, I just want to say one thing. Firstly, of course, your messages are very clear. All of us who are in the periphery, we having in the middle of night previous to cesarean, we must have an idea कि placenta कहाँ है. I mean, we can't do this कि हमने खोल के देखा कि placenta उसके नीचे है. What I am saying is that FIGO does give this कि you can close it. But now it has gone a step ahead, because suppose what is the indication for you to do the cesarean in such a hurry? Then you can't close it. If it is for the fetal indication, you have to take out the baby in such a way
previous
that you
to
don't disturb
cesarean
the
section,
placenta.
elective surgery,
Not
Madam,
to do, not to
yes.
do. No, not to do. Then you should not be caught in this.
Yes.
Yeah.
So if it's a
Then you
fetal
can easily
indication,
avoid
fetal
this.
distress, then a
Yeah.
different matter. But if it is an elective C-section, the
Not,
patient is
if
not
you are
available.
selective,
Dr.
it has to be
Surekha,
not at
one final message is 2 previous sections, placenta previa, even if they have given it as not accreta or anything, you have to consider it
Even
as
with one cesarean also, it could be.
Dr. Surekha, I would just want to summarize in one line. Any case of previous cesarean, if having we must always get ultrasound prior hand, and whether the placenta is upper
I
and
think
lower.
these are
And
very, very good messages. Very, very good messages.
Then take it as a case of pass until proved otherwise.
Finally, Dr. Deepak wants to say something here.
See, any patient with a previous LSCS with a placenta previa in a small nursing homes where blood facility is not properly available.
Don't undertake.
Good surgeon.
Yes.
Even sonography says that there is no.
Absolutely true, Deepak sir.
You can get sometimes it is a report can get misdiagnosed and you will land up in a trouble. So when you see the previous,
So the golden rule is avoid forced placental removal. If it is not coming, don't give traction on it. Don't try to remove, and recognize the placenta accreta syndrome early, which will be life-saving for you also and for the patient also.
Can I add something, Dr. Surekha?
Yeah.
Any previous cesarean, if the patient is coming to in the first trimester, please rule out scar ectopic. You will save the placenta accreta and manage it at that time.
Okay,
only.
okay.
So,
So
because
let
scar
me summarize.
ectopic is the precursor of placenta accreta syndrome.
Absolutely.
Okay, so the golden rule I have already said: recognize early, multidisciplinary team approach. If you as many people you have, you will have to call them damage control. Shift from routine to a damage control obstetrics. Trigger massive transfusion protocol, and of course avoid forced placental removal and do a rapid hysterectomy here. And of course, as Dr. Manjupuri said, put your fist on the aorta.
We have Dr. Pelli's aortic clamps also available.
So that may not be available everywhere. You may not be well versed with them.
But he
But
has.
you have your
Many
fist with
people
you,
are not
and you
trained in that.
Yeah. So that may be a problem, but you have your fist, which you can nicely, compress the aorta. So deeply impacted head. Would you like to take this case, Dr. Parikshit?
Yeah, I'm here.
Yeah.
So this is another very typical situation where, in the second stage, we are called upon to rescue the baby who is stuck in occasionally a deep transverse arrest or a persistent occipito-posterior. Now, the problem here, of course, is that the uterine incision has been made and it's difficult to get the baby out. Dr. Taide, next one, please.
Yeah, so she had a lateral extension. That is what we are talking about here. Yeah.
Okay. And now we have delivered this baby, and after several attempts of disimpacting, etc., the baby is delivered, but we can see that there is a active bleeding. And when we trace this, the common finding that one might get is that you have entered into the broad ligament or there is an extension of the uterine incision. So let me begin with Ashwin sir.
Yes.
Sir, how do you approach this on the table?
First and foremost, just exteriorize the uterus. So that will be give the more idea regarding the extension of your incision, and mostly straightway lateral extension, then it will lead to the involvement of the uterine vessels. It may bleed profusely. So use the proper suctions and catch the vessels which are bleeding. Particularly here, the green hermitage will be more useful, or ring forceps will be useful. Once you have the adequate hemostasis, do the proper suction, adjust the light, and identify where the tear is extended. If it is straightway just up to the lateral margin, not extending in the broad ligament, then you can start the suturing. And one more thing, if it is extend downward, caudally toward the bladder, then again you have to be very cautious. You have to separate the bladder properly, centrally as well as little bit laterally, so that you can avoid the ureter ligation accidentally, and then start the suturing.
The role of mobilizing the
one
bladder.
thing which may occur is that you might have a lot of hemorrhage because of vascular injury. And you think that you'll be able to control this, so you compress it, but then eventually you land up with a broad ligament hematoma. So Aswat, what is your approach? First, you will please answer, and then Dr. Desai will answer.
Okay. See, my approach is simple. As things which I am not repeating what sir told. If the bleeding is not stopping with this, either you may have to ligate the uterine artery, low ligation of the uterine artery on both sides if possible. Okay, uterine artery, that is the first step. If you are not able to manage the uterine artery, you may have to go and ligate the internal iliac artery to stop the bleeding. Okay, so how do you take the uterine artery? The message is that you have to do a low ligation, not that you do at the. So one more thing, the thing to prevent this is that whenever you are doing a difficult cesarean, you should put an adequate incision initially itself. Many times we feel that a small incision, we may be able to deliver a normal baby. So incision should be adequate so that and then sudden pushing of a de-impacted, when you take the head up, then you push it suddenly. That is the time when suddenly the tears. And see to it that sir has slightly told the last point. You have to dissect down the bladder so that extension going down should be seen. Once the broad ligament hematoma is formed, you have to evacuate the hematoma. Many times you may have to ligate the internal iliac artery. This is my message.
Okay, thank you, sir. Yes, Deepak sir.
If the extension is low down, going towards vagina, that time separating bladder and all, sometimes you can damage the ureter. So it is better to go directly for that side internal iliac. That will save the problems. Other thing is that to prevent this, the incision on the uterus, normally, see, most of the people extend it like this. So that itself gives a, that can extend. So if you extend the incision craniocaudally, the vector will go and end at the end, at the crossing, at the end. So it will not extend. So most of the times, if you extend craniocaudally, by vectors, the extensions are usually not seen. We have not seen extension for last almost 25 years. Just because
we are talking about this impacting from below, and that push technique.
So that is a good preventive step which Dr. Desai has given.
Yeah, Dr. Pramila.
In such
Malik wants to add something.
In such a deeply impacted head, first of all, when we are giving the uterine incision, we have to be careful. It should be just 2.5 centimeters below the UV fold. Otherwise, you may go into the cervix or vagina. Secondly, when you are extending the uterine incision, it should be a very controlled incision in a smiley face with the scissors, not with the hand, because it's very thinned out. So you have control over where you are going, and it should be directed upwards. And thirdly, when you give the incision and you find the head is deeply impacted and the shoulder is presenting, the best way to deliver such a baby is by Patwardhan's technique to avoid any extension.
Yes. These are
Patwardhan
all
doesn't
good,
lead
very
to
good
any extensions.
points for preventive aspects.
Yeah.
And excellent inputs. One very simple thing, what I keep in mind is that if the station is 0, take the incision where you normally take. If the station is +1, then you take it 2 centimeters higher than what you would normally take. So that helps to not go too low down into the lower segment and closer to the vagina.
Yes.
So this is just a rule of thumb that one can follow.
So
So one of the problems that can also occur, Kiran, I'm going to ask you this question, is that the extension might actually be very difficult and it may have gone even into the vaginal fornix. Have you encountered such a situation? So I'll ask your inputs and Dr. Kabra's inputs on this question.
Yeah, thank you, Parikshit. Actually, again, without repeating what all the panelists have said, what my plan is generally in such cases of deeply engaged head is decide what incision, what method you are going to, method you are going to implement. Is it Patwardhan or is it disimpaction? So being in two minds about it, how you are going to deliver is going to cause problems. I go generally for the Patwardhans, giving the incision at the level of shoulders so that I can plan the incision. And the problem that I expect with this, if at all, is the lateral extension. Whereas if it is the impaction, disimpacting the head and all, it is the vertical tears which are going to happen. So generally, I don't prefer these vertical tears. I feel confident to manage the lateral extensions, and they don't happen if you really plan well and do. So regarding the colporexis, I've seen a case of ruptured uterus where it has gone into the lateral vagina, and unfortunately, because patient was in shock and all, there was a hurry to control the bleeding and all. The curator was involved, and we were trying to suture the edges, and the tearing of the vaginal walls is very, very common if it is vagina.
It's a very difficult
It's
situation.
a very difficult situation. And we called the urologist, but anyway, we had to close, and then later we had to go for a stenting. And vagina, ureter is a real risk here if it is a lateral vagina and the colporexis.
Just 1 second, Dr.
And
Pariksit.
one case,
1 second,
Mitra ma'am,
Kiran.
yeah.
No, 1 second. Shreya, please post the post-test link in the chat box. So we will not stop the panel discussion. All the members are requested to continue doing the post-test. Meanwhile, we can carry on the discussion. That's it. Please go ahead.
Ma'am,
We get another 10-15 minutes.
Sorry to interrupt. मित्रा मैम, शेयरिंग आपको स्टॉप करना पड़ेगा क्योंकि मुझे स्कैनर दिखाना है मैम.
कोई आप लिंक डाल दो और 1 मिनट के लिए दिखा दो.
From my side, I wanted these questions to be discussed.
No,
Dr. Taide can continue with next case.
No, Dr. Pariksit. We want you to continue the panel.
Yeah.
So the link can be posted. You can put the scanner after a little while, Shreya. Post the link in the chat box. We want the panel.
Yeah, if I can continue, I mean, one
I
case.
need to go, so rest of the panel
share.
again, Dr. Taide will continue.
Hello.
Okay.
Can you hear me?
डॉक्टर शीला आप बताओ क्या करें भाई.
देखो, अगर हम लिंक बीच में डालते हैं तो उन लोगों को थोड़ा स्कैन करने में टाइम देना पड़ता है और फिर बार-बार
I have stopped sharing and you may go ahead with whatever is needed.
नहीं हम चाहते हैं कि पैनल चले मैडम, सब लोग चाह रहे हैं.
If they give consent for continuing the panel, then I think that panel can be done and later on the MCQs can be displayed.
No, MCQs link can be displayed later on after the panel.
Can I speak, please?
Because the comments are saying that they want the panel.
Wait for a minute. Wait for a minute. What I am trying to tell you is, right now, if you stop share the scanner for a while, put the link in the chat box. Chat box link will continue. Those who want to answer through the link, they will answer there. Those who want to use the scanner will use. Again, we will continue the panel.
Yes.
Again, you again put the scanner if there is a request in the chat box. Okay, that's all.
Okay, ma'am.
Yeah.
Okay, ma'am.
Just pause for 1.5 minutes.
We have already done that, ma'am.
Yeah.
So anyways, we have 2 cases more. One, I wanted to show a broad ligament hematoma. And then I also have some few questions on if there is an inadvertent bowel injury. So these are 2 things that is very important.
Panel is ma'am, very informative.
Yeah, so 10 more minutes probably. We started late also.
Yeah.
And we are right on time, I think.
No, that's what I'm saying. Everybody, please scan the scanner and go into the chat box, open the link and attempt your post test. And then we will start the panel again.
Sureka madam, I may leave around 7. I have a case, madam. Okay.
Not an issue. We'll just finish in the next 10 minutes. The key messages probably, and we can finish.
No problem, madam. You continue in between, even if I may leave. Sorry, madam. Continue.
I think we can continue, Surekha.
Yeah, so this, I think this
you can share your screen.
Scanner has to stop. Then only I can share my
Shreya, please, unshare so that Dr. Surekha can share it. Yeah. You can share now, Surekha.
Yeah. So I don't know where I was. Okay, we are talking about colporexis.
Vertical and transverse colporexis, yeah.
This was a colporexis, which I had showed a slide here.
I just wanted to share one case where it was an obstructed labor. LSCS was done. Nothing was suspected, but later on a dirty discharge was coming from behind the bladder. Then when we saw it was a transverse tear in the vagina, well below the cervix.
Yeah. So identifying, how do you identify?
Yes.
Yeah, the cervix appears actually detached or floating upon exploration. Many a times, you're not able to see anything because of the amount of bleeding which there is. If the cervix appears to be floating and there is a massive expanding broad ligament hematoma, probably you have to suspect the colporexis, and rightly this has been already been talked about. Very important is to don't do blind clamping. You may injure the ureter. Rightly Dr. Kiranmani has pointed out that there was an ureteric injury here. Use of course, once you identify the vagina, then you can suture very well, grasp the vaginal margin with ring forceps. Sometimes maybe of course don't use too much force there. Ischemic injury can also occur because of the clamps which you are using, so be careful. And that is how it's the clamp edges restore the clear visualization, and of course the vaginal vault margins have to be identified. Positively identify the cervix, where is the cervix, where is the vagina. Sometimes this merges. Identify the bladder reflection, ensure that the bladder is safely mobilized, and then take the sutures. I think that is how.
Can I add something,
May I
Dr.
give one
Sureka?
suggestion? When there is a complete transverse colporexis, that time you try to push the bladder and try to identify one clearly visible part of the vagina. Apply a space suture over there, and then gradually lifting the space suture, you can easily trace the whole ring.
Yeah, previously I know my professor used to initially only place the suture on the lower uterine segment, so that later on they are able to identify. Even in my institute here, even now that technique is used, where they put a
Can I
space
add
suture.
something, Dr. Sureka? Whenever there is colporexis, when we are repairing the vagina, it's very important either to lateralize the ureter, this thing, to avoid ureteric injury, or to involve a urologist so that he can do a ureteric stenting.
If you think that there is an extension into the broad ligament in such a way that the ureter may be involved, then
because even during
urologist.
repair you can injure the ureter, so it's better
And of
to
course
involve
the
the
tissues are
urologist.
very fragile. Sometimes you just put
Post-operatively, they say you can confirm with a cystoscopy also.
In fact, Dr. Sureka, whenever we suspect or we have an apprehension about causing ureteral injury, what we do, most of the time the partial peritoneum of the retroperitoneum is open. Otherwise, we just enlarge it little bit. We do a good dissection. We push the ureter even more below. It can be
so this is the
then
question for you. How do you repair deep lateral tears while maintaining vigilance for ureteric injury? Is there some technique by which you can so blind clamping you should not do. Suturing in a pool of blood without clamping or without identifying, you should not do.
Exteriorizing the uterus, madam. Always exteriorize the uterus. There are habits, many places where they keep the uterus inside and suture. That never should be done. Exteriorize the uterus.
And if there is an extreme tears, too much the distortion of the anatomy, then have your urologist friend or your surgeon friend there with you, so that you do not clamp or inadvertently injure the ureter. So
can I
this is
give
all
one line, Sureka? The biggest mistake is trying to do things fast. Inform your anesthetist that what is the soup you are in. Press everything. Have the lights and the retractors and the assistants with you. Visualize the direction the tear has gone, this way or that way, and then try to stitch. बहुत ज़्यादा hodgepodge करने से things get more and more complicated. So
and I think the final message is, when you're doing these deep extractions, pushing for below sometimes I have seen all the traumas with this, but there are other methods like reverse breech extraction, like the Patvardhan's technique. If you master these extraction techniques, probably you may avoid these kind of extreme tears because for so many years now I haven't seen with the Patvardhan's technique, our even residents have mastered the technique. So that is one preventive technique I think.
Patwardhan is excellent for impacted head.
Excellent.
And madam,
yeah.
you have to popularize it, because many of the people, if Patwardhan is not applied properly, the tire may extend like anything. So you have to train our postgraduates or whoever, or at least they should at least have experience, at least see from somebody who is experienced doing Patwardhan. Otherwise,
I
it will
have
be.
Patwardhan
No, you
videos,
need
so
to
anytime
get
I
trained.
can
You need to
show
get
Yeah.
trained. And another
Okay.
message is intentionally extending in the either in a J-shaped or upward extension is far superior than any traumatic extension. So you should have an adequate extension. That is another message which we can give in this case. Of course, communication and documentation, these are very important. This is another case of retroperitoneal hematoma. And what I wanted to ask question is, Dr. Parikshit is there? You would like to take this case, or is he not there?
Dr. Surekha, before this, I just wanted to add one line. Why we have reached up to the stage of doing a second stage cesarean? We should also focus on preventing.
No, let's not talk about that, madam. We have a lot more to discuss. I think that can go in another panel. What I wanted to talk about, if you have a hematoma, when would you?
It
What is the
depends upon,
threshold?
madam.
Dr.
It
Deepak.
depends
Dr.
upon.
Deepak, what is the threshold? Would you observe? Would you explore?
Not at all. Hematoma should be explored. And
Even if a small hematoma is stabilizing, not increasing, what do you say?
still explore. Always, even a small hematoma, there is a bleeding. That's why there is a hematoma.
No, if the
Anybody
patient
wants to differ?
Yes,
Anybody
yes.
wants
If
to
the
differ?
patient's vitals are stable, we have to observe the hematoma. If the patient's
If it is
vitals
very small, not
yes,
expanding,
if
you
the
may
patient's
press upon
vitals are
it.
stable and the hematoma, you observe it for maybe 5 minutes, 10 minutes, it is not increasing in size, and the patient's vitals are stable, we don't touch it.
No,
Madam,
not
I
on table.
disagree
Not
with it.
on table.
Disagree
Small,
with
very
it.
small
Not when,
hematoma.
no,
I
no.
totally
Pramila,
disagree, because it's
I
not
am
like
with
a
Dr.
closed
Ashwin.
abdomen
Because
where inside
No.
there is a small hematoma. Here we have opened it and we are
You
seeing a
cannot
hematoma
keep,
that has
exactly.
to be evacuated and
no,
suture
no,
has
if
to
it
be
is,
put.
Dr. Surekha is asking, very small hematoma, not increasing, patient's vitals are stable.
Whatever
No,
it
no.
is, even if it is not increasing, you
No,
have
no, you
to
have to press it and
evacuate
see
the
it
hematoma
should
and suture
reduce.
it. This
It should
Okay,
hematoma
reduce.
we
may.
have
It should
we have a debate here. So basically, what we are talking of is, very small. Sometimes it happens that there is a blurring there, but not exactly a hematoma. Yes, rightly said. If the hematoma is forming and expanding, you definitely have
then
to
it has
open
to
that
be,
lip.
it
Then
has to
it
be
has to be
evacuated.
open, and you have to see where is the problem, and you have to take care of it.
Suture
So
it.
how do we reliably identify and isolate a bleeder in case of this kind of chaos which is happening there? Anybody would like to talk about this? Dr. Deepak.
In large hematoma in a broad ligament, you will not be able to find the bleeding vessel. You don't directly go for an internal ligation. That's the thing. In a small hematoma, the problem you just said, you have to just open it and even if it is not there, the bleeding vessel, just forget it. But if you see a small vessel, so you have to, whenever there is a hematoma, you have to open and see whether it is bleeding.
So directly internal iliac ligation you want to do, or you want to evacuate that area, check if it is
Type of
controlled,
hematoma,
can
I
be
will just
possible.
open it and ligate the vessel. The
Vessel is there, the uterine artery is there. If you can manage with the uterine artery ligation there, then you may not do internal iliac ligation
not for
all the
this.
time.
Large lateral wall hematoma.
Large lateral wall hematoma, definitely you would like to do a damage control first, you may. But otherwise, you can evacuate, as you can see in this video.
Here,
The
here
evacuation
you
is
do
there.
the internal this uterine artery ligation.
Yes.
Dr. Deepak, I think let's go back to the vascular anatomy of uterus. For managing the hematomas in and around uterus, you really don't need to go to internal iliac. We know that we have to ligate the uterine artery.
So here you can rightly see that the uterine artery is the one which is bleeding. You identify the vessel and you can do the uterine artery ligation. You need not do an internal iliac ligation.
The only thing is to safeguard the ureter. When you are ligating the retracted uterine artery.
Manju, please give your comment. Dr. Manju.
Dr. Surekha, can I come, please?
Yeah, Dr. Manju.
Yeah. So basically, let's understand that if there is a hematoma, we need to explore, open it up, see if a bleeder can be identified. If a bleeder can be identified, ligate that. Otherwise, go for internal ligation of that site.
So here you can see very nicely the bleeder is identified, as you can see on the screen. And when you do the ligation, the bleeding is controlled. So in this case, need not do an internal iliac ligation.
Yeah.
But if it is an expanding hemato, you're not able to see anything, the first and foremost thing, you can first go for an internal iliac ligation. I think that is a clear-cut message. We can go, and if the damage control is not happening and still the patient is bleeding, then you should be aware of the escalation pyramid. You could go for a hysterectomy, pelvic packing, internal iliac. So you have to, do these things depending on what the situation is.
Hemodynamic stability of the patient.
Do not delay a life-saving hysterectomy if needed when conservative managements fail. That is again one key message which should be given. So when vascular ligation fails, stop clamping, stop packing. Do not delay a life-saving hysterectomy. That is a key message which we like to give. Now coming to the last case, is Dr. Parikshit here?
Okay, Surekha, I think you can leave this one because we are already over.
I'm okay. This was about bowel injury, but only, of course, key take-home messages is that prompt recognition, multidisciplinary team approach, and safe surgical techniques. These are very important to resolve any intraoperative crisis and requires simultaneous activation of all three pillars to prevent catastrophic maternal and fetal outcome. Thank you very much, all the panelists. It was very engaging, very, very, very enthusiastic and energetic panel. Thank you so very much.
Thank you so much, ma'am. Lots of
Thank you.
Right?
Wonderful panel, Dr. Surekha and Dr. Prateek.
Have been a better team, moderator and panelist on this topic.
Thank you so much.
Nivedita,
Ma'am,
everybody has submitted the test. You can show the answer key, then do the thanks.
So thank you, Dr. Surekha and Dr. Parikshit and all the panelists.
Ma'am, 1 minute left.
For a wonderful panel. And I think moment the time is over, Shreya, please let us know. And Nivedita, would you be sharing the answers?
Yeah, Shreya is doing it, ma'am.
Manju ma'am, 1 minute left hai.
Yeah, please take your time. Right. And one more thing which I would like to add at the end is whenever there is a bowel injury, it is important that we mobilize the bowel, and if there are adhesions, they should be released. Because once we had this, someone had just repaired it without releasing the adhesions, and it gave way because the bowel has peristalsis. So it should be allowed to move. And if it is bound in the adhesions, then the stitches which you take can give way. So that is something which is important because the surgeon there did not mobilize. He was a young surgeon. So I guess that it is important to mobilize that. But anyway, very good inputs and.
I'm Rekha and Parikshit, very good. I think excellent discussion. All were so much interested. And I think there are some questions asking for yesterday's questions. I would like to tell you that now it won't be possible to give you that. Anyway, you will be getting a certificate. So what we will start doing it is, now when we send the certificate to all, we will start attaching these test questions also, Manju.
Yeah.
So those who have missed it and if they want, because we send the certificate to everybody through ICOG.
Perfect.
So that time we will attach this. So
that's
you
a
will
good
get
idea. That's a good idea.
To again project it today. Okay. So
and one more important thing, Dr. Sheila, which again I am asking them to do is that all the videos are in the masterclass on PASS on the ICOG website. So I request everyone to please look up that link there, and you will get everything there. You know, all the videos which were shown by Dr. Saha and even more videos, how to dissect the bladder and all are there. So please go and go to the website, visit that website. And
ICOGonline.org.
There's one question for Surekha ma'am from Indra, IMS Patna. How do we suture very thinned out lower uterine segment?
Where is Surekha?
Patient note come better na.
So basically, when you have a very thinned out lower segment, it is important that we dissect the bladder off and we excise that part of the, segment, especially the previous scar where there's dehiscence. We remove it and get a healthy tissue and then join it. So that is the way out. Dr. Deepak, do you want to give any inputs, or Pramila? Anyone from the panelists would like to give some inputs?
Some input,
Yeah,
ma'am.
yeah.
Yeah.
Shashi, please go ahead.
Usually what happens, the thin down lower segment has got a bigger length compared to the upper segment. So what Madam has said, you must always do it. After that, if you can, in the lower
Transfer
segment, you take
stitches,
two stitches together. So the length will become small. And then you apply, in the upper segment and lower segment, you apply figure of 8 multiple sutures that will.
Yeah. So transverse pleating sutures can be taken at the lower
In
part.
a very thinned out, when the lower flap is very thin, we can take double bite in the lower flap.
Yeah, double transverse bites.
That doesn't
So that
cut
will make
through.
the length smaller.
No, but that doesn't cut through. If you take the double bite in the lower flap and then go, then it doesn't cut through.
That's what Manju is telling, na pleating. Running suture.
I take a horizontally running stitch, and as Madam Pramila said, I take a double bite in that. So that, brings it quite close, and it doesn't cut.
But scar dehiscence, one should excise the scar. I think people don't do that. So
Yeah.
you please excise the scar and then take healthy myometrium on both the sides and do a good bladder dissection. That is the mantra. Bladder dissection, you all must you must master bladder dissection. Don't hesitate in dissecting the bladder. That is important, right?
Nivedita, wo laga do answer ki.
Okay, madam. Bye-bye.
Bye-bye. Thank you, Dr. Deepak. Thank you, Pramila. Thank you.
Thank you so much. Thank you so much. Thank you, Dr. Mitra, Dr. Manju.
अभी रुक जाओ, वो बच्ची देगी ना. Thanks.
And everybody. Thank you.
So, thank you, Dr. Kiranbhai.
You have to read out the answers.
Go to day 2 post-test, the answers for that. The first question was, first step in managing sudden massive bleeding during Caesarean section is, the answer is B, call for help and activate massive. The preferred initial surgical technique to control uterine atony after failure of medical management is, the right answer is option B, compression sutures. Third question, tranexamic acid is most effective in postpartum hemorrhage when administered. Of all the 4 options given, correct answer is A, within 3 hours of bleeding onset. Otherwise, within 30 minutes, half an hour you should begin. The most important principle in managing an extension of uterine incision is, answer B, identify the full extent of injury before repair. Question 5. A 32-year-old woman, gravida 3, para 2, live 2 with 2 previous cesarean deliveries is diagnosed antenatally with placenta percreta involving the anterior lower uterine segment. During planned caesarean hysterectomy, the most appropriate initial surgical step to minimize bladder injury is. So this is from Dr. P.K. Shah. The answer is option C, perform upfront dissection of the utrovesical space before uterine incision. 6. During caesarean hysterectomy for placenta percreta, the placenta fails to separate spontaneously. The surgeon should, option B, leave the placenta in situ and proceed with hysterectomy. Question 7. Which of the following surgical principles is associated with the lowest risk of catastrophic hemorrhage during caesarean hysterectomy for PAS? Answer is option C, avoiding incision through the placenta by selecting an alternative uterine incision. 8. The fundamental principle of one-step conservative surgery for PAS is, answer C, en bloc excision of invaded uteroplacental area with the placenta left attached, followed by uterine reconstruction. 9. Which of the following intraoperative measures has the strongest evidence for reducing maternal morbidity in women undergoing surgery for PAS? Answer B, simple multidisciplinary team management with planned delivery in an experienced PAS center. 10. A 30-year-old woman with 2 previous caesarean section undergoes a 3rd caesarean delivery. Dense adhesions are encountered between the bladder and the lower uterine segment. Which is the most appropriate initial step? Option B, identify normal tissue planes and proceed with meticulous sharp dissection. 11. Pelosi maneuver during dense adhesion is, right answer is C, entry through broad ligament. 12. Which is the most common intraoperative complication associated with dense adhesion during repeat caesarean section? Obvious answer B, bladder injury. 13. 40-year-old mother, IVF conceived, is planned for caesarean section due to multiple pregnancy with breech presentation at 39 weeks. She has a past history of being on anti-anxiety drugs, off and on. On the way to OT, she complains of recurring breathlessness on lying supine and feeling very low. Her oxygen saturation is 90% on room air in supine position. Pulse rate is regular, 104 per minute, and blood pressure is 120 by 80, respiratory rate is 26. This question is from Dr. Vivek Saluja, and the correct option is urgent echocardiography. So do echo before proceeding for surgery or anything else. 14. 33-year-old primary gravida with gestational hypertension was having a planned caesarean section under spinal anesthesia for placenta previa. Surgery was proceeding as planned. After delivery of baby, oxytocin was given, 5 units, slow IV bolus. Soon after that, mother complains of chest tightness and itching all over. Facial swelling was noted. BP was 70 by 40 and pulse was 120. What's your diagnosis and what will you do first? So this is possibly anaphylaxis due to oxytocin. Stop the oxytocin drip and give IM adrenaline. So this was also dealt by Dr. Vivek Saluja. Following the most common form of anesthesia for caesarean section, patient shows bradycardia and profound hypotension. The most likely cause is high spinal. C. Intravenous 20% intralipid is used in case of intraoperative maternal collapse following what is suspected. So the answer is last, local anesthetic systemic toxicity or like bupivacaine toxicity after spinal. Number 17. Which structural property of pili forceps reduces compressive trauma to the fragile preterm fetal head? Right option is C. It's a more compact, lighter design featuring thinner blades to minimize lateral compression injury. 18. Which is the most widely accepted teaching regarding myomectomy during scheduled LSCS? Option C. It is generally avoided for intramural fibroids, but pedunculated fibroids may safely be removed. 19. What is the primary physiological reason that myomectomy is deferred during intrapartum caesarean compared to non-pregnant state? So the right answer is B. Massive uteroplacental blood flow of 500 to 800 milliliter per minute increases bleeding potential exponentially. And last question. According to WHO definitions, how are preterm, very preterm and extremely preterm births correctly categorized by gestational age? So straightforward answer B. Preterm is less than 37 weeks. Very preterm is 28 to 32 and extremely preterm is less than 28 weeks. Thank you.
Right. So thank you. This brings us to the end of day 2 of the certificate course on complex cesarean section. Thank you, Nivedita, and thank you, Ashima, for coordinating it, and you've done it brilliantly. Thank you to all the faculty members who have participated as speakers and as moderators and panelists. It's very good inputs. It was wonderful to have experienced people with us, and of course, thanks to the sorry.
Shreya and Nilima.
Yeah, Shreya and Nilima for the back-end support. And of course, we thank the ICOG team for promoting such wonderful sessions. And is proud to be a part of the ICOG team. Mitra, do you want to thank anyone else whom I have missed?
Many people have asked for panel discussion again because...
No, so... Again, I'm telling that the recordings of this also will be available on the ICOG website. So that is what you must understand. All these recordings are available. Try logging in to the ICOG website and look up. Yeah, so
they want to know why.
ICOGonline.org. Another thing is that Dr. Sheila Mane has promised that you will get the questionnaire in your email, so you can answer it then. All those who have logged in today and yesterday and who will do tomorrow, we will make sure that you get your knowledge bank with you.
And moreover, all the questions, if you have seen, are the ones which were discussed in the lectures. So it is important that you focus on the lectures and don't worry about getting the recordings. The recordings are going to be there, right? So we, again invite you for the last day, tomorrow. Yeah. So be there and be ready for the post-operative problems which are likely to be there, right? So first day was preparation, second day was intra-op action, and third day is post-operative. Over to you, Mitra.
But my last sentence and humble submission is that don't underestimate the power of even a normal cesarean section. All the problems that will be covered tomorrow are any one of us would have experienced any number of times. Lucky if we are very sincere or we are very careful, but I'm sure you're going to find many, many cases which you have experienced in your practice. So please spare your time again. Those who cannot join, never mind. Go on the net, listen to the recording, try and log in live. And for any goof ups, I apologize. Maafi meri.
Thank you so much. Thank you so much. Thank you, Dr. Sheila.
Thank you, Manju. Thank you, Dr. Sheila, Dr. Prateek, all our guests, Dr. Sadhna, Dr. Ashok, and the seniors, faculty, everybody. Good night.
Thank you, ma'am.
Thank you, Shreya and Nilima.